Good morning, everyone, and welcome to our Mastering Melanoma Symposium, a symposium for patients and caregivers. This is a joint symposium put on by Melanoma Research Foundation and the University of Texas M.D. Anderson Cancer Center. And I just really want to say thank you, everyone, for joining us on a Saturday morning. I think that this virtual format really highlights both the benefits of being able to have this type of format as well as some of the drawbacks. And so it is a cold morning here in Houston, Texas, for those of us that are here or in Texas. And so it's quite nice, I think, for many people to be able to join from their cozy living rooms on a Saturday morning. At the same time, we really miss seeing you and engaging with you and learning a little bit more about you, and for you guys to also, as patients and caregivers, to interact as well. I would encourage you as you join, actually, you'll see that there are two boxes. We have a chat box and we have a Q&A box. The Q&A box will be used for questions that are directly to our speakers. We will be addressing questions as we go at the end of each session. In the chat, though, that is where I encourage you to actually introduce yourselves. Tell us about where you are, if you are an MD Anderson patient or not, where you are in your cancer journey, whether you're a patient or a caregiver, or just somebody curious and learning a little bit more about melanoma. So again, we do encourage you to kind of let us know where you're coming from. So our objectives today, we have really made such tremendous progress in the treatment of metastatic melanoma, really more than any other cancer this decade. Historically, the long-term survival for melanoma in the metastatic setting has been poor. Less than 10% of our patients were surviving long-term. With the advent of the new immune and targeted therapies, which we'll be discussing today, now our long-term survival is greater than 50%. So obviously there's a range of stages of people that are here joining us today. But again, we've really made such strides in this long-term survival in the metastatic setting. What we'll be discussing today is what is the progress that has gotten us there. And so here we have a survival curve, basically showing that about 50% of our patients now with metastatic disease achieve long-term survival greater than 5 years. What are the treatments that have gotten us there? And then from this new generation of survivors of metastatic disease, what are some of the elements that we now think about? However, we also recognize that not every patient has benefited from these new therapies. Not every patient's melanoma will respond to these therapies. And so what are those unmet needs? How do we do better? And what is the state of current research and of upcoming treatments for melanoma? Our agenda, again, my pleasure to welcome you this morning. I'm an assistant professor in melanoma medical oncology at MD Anderson Cancer Center. Amy Marbo will then be giving us an introduction to the Melanoma Research Foundation and the many programs and resources that Melanoma Research Foundation provides. We will then have our first session, which will be focused on the treatment of melanoma, moving from melanoma staging and surgical perspectives to then looking at treatment in the neoadjuvant or adjuvant setting, mainly for patients with regionally metastatic disease to lymph nodes. We'll also be talking about our two major types of therapy, so targeted therapy and then immunotherapy. And then kind of our final frontier in melanoma, which is brain metastases and leptomeningeal disease. All of these speakers are physicians in either melanoma surgical oncology or melanoma medical oncology at MD Anderson Cancer Center. I will note that everybody is joining us live other than Dr. Amaria and Dr. Glitza. Both actually had other engagements. Dr. Glitza is currently rounding on our inpatient service. Dr. Amaria had another symposium to actually attend, and so they have pre-recorded their talks. We will have time for brief questions at the end of each talk, but really we're going to be answering most of the questions in our question and answer panel session at the very end. We've structured session 1 in this way because all of us as melanoma medical oncologists and surgical oncologists will also be able to address various questions around targeted therapy, immunotherapy, and surgical perspectives as well. And so again, although Dr. Glitza and Dr. Amaria will not be here with us live, the rest of our panelists will be able to address those questions. Session 2 will then be around survivorship. And so we will have Michelle Rolfs, who is our lead advanced practice provider, discuss our survivorship clinic. She is within MMO, and then we've actually engaged a number of experts throughout MD Anderson to then discuss specific domains of survivorship. So this includes neurocognitive function, the financial impact of cancer care, lifestyle management, and then adolescent and young adult survivorship. You'll note that during this session, we do not have a panel at the very end for question and answer, and that's because each of these speakers has very specific expertise. And so I will instead open it up to questions at the end of each speaker's presentation. Throughout, again, please use the chat function to just kind of talk amongst yourselves, introduce yourselves. Formal questions for our panelists will go into the question and answer session. All of our panelists are able to see this. I'll be moderating the question and answer. I would ask that we keep the questions a bit more broad, meaning not specific. We can't address specific questions about an individual's treatment or treatment recommendations. However, if there are questions around that and you're not currently an MD Anderson patient, we will also be providing the information to be able to come see us at MD Anderson and provide either second opinions or further management of your care. With that, I will actually again say thank you for joining us and turn it over to Amy.
Hi, good morning, everyone. I will start sharing my screen for a few slides. Maybe. Uh-oh, can everyone see me?
We can, Amy.
Are you seeing the screen or no? My slides?
Currently nowhere. No, there we go. Now we see your slides. Perfect.
All right, perfect. Sorry about that. Good morning, everyone. My name is Amy Marbaugh. I am the Education Officer with the Melanoma Research Foundation. We are so thrilled to be able to partner with MD Anderson for this Mastering Melanoma Patient and Caregiver Symposia. We are a nonprofit based in Washington, D.C., but we are provide resources and services for patients throughout the United States. A brief history about the MRF. We just celebrated our 25th anniversary. We were started in 1996 by a patient named Diana Ashby. She was a metastatic melanoma patient. She had multiple recurrences and was basically told that there were no other treatment options available for her, and that was really it. And she found that unacceptable, and she wanted to do more for not only herself but for future melanoma patients. And so she started the Melanoma Research Foundation as a way to provide grants to researchers and clinicians to find new treatment options for melanoma, as well as hopefully one day find a cure for melanoma. Unfortunately, she passed away right before we handed out our first research grants, but her legacy obviously lives on as we are now in our 26th year of the organization. Our mission statement is to eradicate melanoma by accelerating medical research while educating to and advocating for the melanoma community. So as obviously in our name, research is a really big area of our work. Since 1998, we have awarded over $20 million and to over 230 projects. I think now we're in the almost 240 projects, which spans 80 institutions across the US, including some MD Anderson researchers and clinicians. We have focuses on cutaneous through our breakthrough with our breakthrough consortium, as well as our rare subtypes, ocular, mucosal, and pediatric. And we also have a focus on brain metastases, which we had our third roundtable with clinicians and researchers late last year, which will result in additional research and information coming out through the MRF. Several MD Anderson faculty participated in that roundtable, so we were glad to have their expertise. Obviously, education is another big area that we focus on. So obviously, patient meetings like this, virtual, and hopefully someday back in person. We have a huge library of online education, from printed materials, webinars, animated videos, as well as a caregiver and patient online forum that's, I'm told, is the oldest melanoma forum in existence. So it's specifically for patients and caregivers to ask questions to each other, to get feedback, to get thoughts and ideas about how to best manage their care. It's completely patient driven, so it's a safe place for patients and caregivers to share their thoughts and receive information. And finally, we have a large advocacy contingency with our organization. So we focus on, a big focus of ours is funding for melanoma research, which is a part of the budget, the federal budget. We have helped to elevate that status of the funding to over $40 million dedicated solely to melanoma research through the Department of Defense. And so that's been slowly, incrementally increasing over the years. And so it's we're advocating for $40 million, which again goes to researchers and clinicians all over the country to better advance melanoma care. We specifically have an annual advocacy days, which this year is virtual, March 7th through 11th, where we help patients, caregivers, and anyone else who's part of the melanoma community set up meetings with your legislators, so your federal representatives and senators, to be able to advocate for melanoma care throughout the spectrum. And so if you're interested in that, please visit our website. We'll have more information about how you can participate in our advocacy days. We have a number of sponsors that helps support all of our patient education opportunities. So we want to take a quick moment to thank all of them. And finally, we are all over the internet. So we are on social media, Facebook, Twitter, Instagram, LinkedIn. I believe we have a TikTok now, if anyone's interested in TikTok. We have a robust website, melanoma.org, where you can find so much information and more information being added as we find new treatment options, new advances, things like that. So if anyone has any questions, you can always reach out to us through education@melanoma.org to learn more. And again, thank you so much for allowing us to be here. We're so happy to support this, and I'll toss it over to Dr. McQuaid so we can get started for the morning.
Excellent. Thank you. Thank you, Amy. And just always so inspirational to hear about all of the work that MRF does, as well as the many resources that you make available to patients and their caregivers. So we will go ahead and get started with session one, actually a little bit early. It's my pleasure to welcome Dr. Jeff Gershenwald. Dr. Gershenwald is a professor of surgical oncology at MD Anderson. He's going to be speaking today about surgical management of melanoma, as well as the staging of melanoma. So in addition to being an expert in the surgical treatment of melanoma, Dr. Gershenwald also has an international leadership role in the melanoma staging systems, specifically the American Joint Committee on Cancer. And so he will be speaking as well about the staging and the melanoma expert panel there. Thank you, Dr. Gershenwald.
Thank you. Can you see, good morning, everyone. Can you see my slides okay?
Yes.
Great. So I also wanted to thank the organizers and MRF for sponsoring this patient and caregiver symposium. It's always a pleasure and an honor to be part of these, and sharing Dr. McQuaid's sentiment. While it's nice to be easy access, it's also really terrific when we have the opportunity to mingle before and after our sessions. So maybe next year we'll be able to consider hybrid schedules that would allow those who would like to meet us in person and allow us to meet you to do the same. Also want to shout out to the Melanoma Research Foundation for their support over the years. One of the early grants in my academic career was from the Melanoma Research Foundation, and then I was able to pay it forward and review grants through the MRF and be part of a lot of the initiatives over the years. And in particular, I'm thankful for their advocacy efforts on behalf of melanoma to support additional research dollars through the federal government. And several of us have been funded by the Department of Defense congressionally directed melanoma research program initiative, and have also served to review grants for others who will partake in this well needed and much appreciated funding to help advance the science. And so to kick off this symposium, what I've been asked to do is to discuss melanoma staging and surgical perspectives. Here are my disclosures, not related to anything I'll be saying today. And before we talk about staging and surgery, we need to think about diagnosis. And just so to set the framework, lesions of the skin, and we're talking here about cutaneous melanoma that are derives from the skin, from the pigment producing cells, the melanocytes. Lesions that are asymmetrical or that have change or variegation of color, or that have irregularity of their border, enlarging diameter, or change in general might be considered suspicious lesions, for which in general it would be recommended to seek some medical attention and ascertain whether this might represent a melanoma or other skin condition. And so here are three examples of someone who might have presented in our clinic after a biopsy. I'm highlighting here where the biopsies were performed. On the left, you might say, well, where's the lesion? Well, the lesion was removed completely with the biopsy. And in the other two examples in the middle and right panel, there were biopsies there that were performed, but did not include the entirety of the lesion because they were too large. And so we'll come back to that in a minute too, to see how that might impact on staging and treatment decision-making. I also want to highlight the importance of an active dialogue. There's no question that's too small for any patient or caregiver. Clinicians and providers should really welcome and invite you to be asking questions early and often. And so in this example here, I show a schematic of an imaginary person who's had a biopsy of their forearm, and the red line is the excision or removal type biopsy site. And in one on the left, it's across or transversely oriented on the forearm, and on the right, it's axially or longitudinally oriented. And if this were a melanoma, the next step is often what part of the treatment called a wide excision, and we'll talk about that in just a moment. But I mention that here because the approach to the surgery and the closure of that area is directly impacted on how the biopsy is performed. So whenever a biopsy is performed for something suspicious, it's okay, and I would invite you to ask your provider, what are my options for biopsy, and then the what if scenarios. What if this does need treatment? Are we considering that as we do the initial biopsy? And so let's say that the biopsy result comes back as melanoma. Now what? Well, a few things that we ask as clinicians of the diagnosis, and the diagnosis is made under the microscope by our pathology team. And we ask, how much does a melanoma penetrate into the skin? If it involves only the epidermis or the surface of the skin, as shown here in this dark purple layer on the right, we call that a melanoma in situ or melanoma in place. And that would be classified as stage 0. It's really a localized process to that portion of the skin. If instead it involves the dermis or beyond into the fatty tissue below the dermis, they call the dermis the business end of the skin because the blood vessels and the lymphatics of the body communicate quite a bit with the dermis. We call that an invasive melanoma, not because it's necessarily invading anywhere else, but because it's specifically invading into the dermis of the skin. And so with that, a pathology report would be generated. Here's an example of a pathology report of someone who's had an invasive melanoma identified. And two of the key features in this report are called the Breslow or tumor thickness, which is measured in millimeters or fractions of a millimeter. That's the extent to which the melanoma has penetrated into or through the dermis. And ulceration. Ulceration is defined as a loss of the epidermis or the surface of the skin over the melanoma, and it's associated with higher risk than if there's no evidence of ulceration under the microscope. I mentioned that the margins or edges of the biopsy are important, and as you can see here, there are a host of other features that we will often use to help filter our decision-making with patients. But the biopsy margins are also critical as well, giving us some guidance as to whether or not there's likely additional process or potentially additional melanoma process around the biopsy site. And we can combine that with the clinical exam as well. When we consider the diagnosis of melanoma and begin to assign some of these features that are related to what we call staging, what does that mean? Well, we use staging to help in our clinical practices for assigning prognosis that helps us generate then treatment recommendations. It's a way that we communicate with each other as clinicians and also with patients and caregivers about the extent of the melanoma. And importantly, as we continue to try to raise the bar in treatment, it's an important element for the eligibility criteria for who might participate in a clinical trial, as well as within a clinical trial, how could we tease out additional information by according to some of the features of the melanoma or the patient that we call stratification within a clinical trial. And then we're constantly assessing the extent of melanoma and other cancers as a problem at the state and national level, and for other research initiatives. And so for reporting purposes, staging is also important so that we're communicating a common language. I mentioned that when melanoma involves only the epidermis or the surface of the skin, it's called stage 0. In general, for anyone with an invasive type melanoma, it'd be one of stage 1, 2, 3, or 4, where stages 1 and 2 are referred to as patients with clinically localized disease, some of whom will have also had evaluation of lymph nodes at risk for spread, but had no evidence of spread in the lymph nodes. Individuals with stage 3 disease are those who have melanoma in the regional lymph nodes or in other sites that we call regional but are not in the lymph nodes, such as satellites or in transits. And I'll give you an example of that a little bit later in the talk. And then patients with stage 4 disease are those who have distant metastasis to distant organs beyond the regional lymph nodes. This is a detailed chart, not to commit to memory, but just to help you understand that there's a true code for how we stage and characterize melanoma. So this is the table for the T category, the primary tumor. And as you see in the second column of tumor thickness, also called Breslow thickness on some pathology reports, we measure this in millimeters or fractions of a millimeter. With increasing tumor thickness, there's an increasing risk. With decreasing tumor thickness, a decreasing risk. And then ulceration is also incorporated. And so taken together, there are 8 categories within the 2-year tumor classification that help with staging. Well, how do we manage individuals who are diagnosed with a primary melanoma? I like to describe this as considering 2 branch points in decision-making. One is how do we treat the melanoma where it was diagnosed? And that treatment approach is called a wide excision of the primary melanoma. And then the other consideration is how do we approach the regional nodal basin And that depends on whether or not there's any clinically suspicious or radiographically evident disease or not, and also the features of the primary tumor to drive that. Well, we'll take one at a time. Wide excision of the primary tumor is performed with what we call margins appropriate for the tumor thickness. And so here on the left are various tumor thickness ranges of an individual primary melanoma. And on the right are the recommended guidelines for margins of excision. And your team will discuss specific recommendations with you on what margin might be most appropriate. And so to better ascertain what we mean by margins of excision, here's a schematic of an imaginary melanoma biopsy in the central portion of this picture. And then this patient was recommended a 2-centimeter margin. And so that 2 centimeters is marked in all directions around the biopsy site or around the residual intact component of the lesion. And then often will be extended then into some sort of elliptical fashion. And there are many ways to close the incision in order to achieve the wide excision. And so schematically, it would look possibly something like this for a melanoma in the upper arm region. Note that the excision also includes the fatty tissue below the skin down to the underlying lining or muscular fascia of that side of the body. And then it's closed usually in layers here with sutures that would need to be removed on the outside, but frequently this could be done with all absorbable stitches depending on where it is on the body. And I just wanted to highlight this in reality as well as sort of one intraoperative journey here. Here's a biopsy site on the just near their shoulder blade and on someone's back, and doesn't really appear that there's any more pigmented lesion there, but that's where the biopsy was and confirmed the diagnosis of melanoma. A 2-centimeter margin has been recommended. We'll come back to the meaning of the blue dye spots there in just a minute. And then the wide excision is performed. And then the adjacent tissue is mobilized, and then this is closed in multiple layers. The next consideration is, how do we approach the regional lymph node basin? And we asked a question over the years for patients who present with a melanoma and don't have any evidence of clinical disease in their nodal basin, knowing that for a subset, there's a significant potential risk of having microscopic spread into the lymph nodes. Is there a relatively non-invasive and accurate way to determine which patients have lymph node involvement and which do not? And this is part of the question that we ask to help to navigate some of the treatment goals when there is disease in the regional lymph node basin. For one, if we identify the disease, we can more appropriately stage the melanoma and then develop treatment guidelines that would be more relevant to an individual. We know historically that when melanoma does develop in a lymph node basin, by lymph node basin, consider the neck area, the armpit or axillary area, the groin area as prime examples of potential drainage basins for a melanoma that arises on the skin. When melanoma develops in the regional node, it can become challenging to maintain control over. And so surgery has been a hallmark of that approach. We also recognize that early intervention when disease is limited, and even in some cases when disease is perhaps more extensive, there are potential therapeutic considerations as well, where we can improve survival with these kinds of surgical maneuvers. And we'd like to do this in a minimally morbid way with the fewest side effects possible, knowing that any kind of lymph node surgery is de facto associated with risks of potential complications because we're altering the physiology of a patient. And so with that, the late Don Morton, about 30 years ago, hypothesized that we could literally map the flow of lymphatic fluid, the area that drains the cells where the melanoma was diagnosed, towards lymph node basins. And so this concept of lymphatic mapping to identify the so-called sentinel node or nodes, the ones that receive the direct drainage from it, in this example, an imaginary melanoma of the abdominal wall, that drains to both the left groin and left axillary area, noting that different regions of skin will drain to different sentinel nodes. So there isn't just one key node in a particular basin, but at the individual level, there's a node that drains particular segments of skin of the body. And that these lymph nodes that receive the direct drainage are the most likely to contain metastatic disease, if any are involved. And so early on, the approach was to use a blue dye injected into the dermis. I said that's the business end of the skin where the lymphatics begin. It commingles with that fluid, and then as it carries away, you can make an incision to where you think the lymph node might be, and then try to identify the node that receives the drainage, the so-called sentinel node. Compared to removing the whole compartment of lymph nodes, which was the only other alternative at the time, where there might be in the axilla, for example, 15 to 30 lymph nodes, now on average removing 2 lymph nodes, sometimes 1, sometimes more, we could ask the pathology team to cut this up like a loaf of bread, apply some special stains, and really try to find that needle in the haystack in a way that we couldn't otherwise offer in terms of a pathological analysis if it was an entire lymph node basin. And so one of the questions is, should I undergo this procedure as part of my treatment plan? In general, for melanomas that are at least 1 millimeter, for some significant fraction that are 0.8 to 1 millimeter, and for a small subset that are thinner than 0.8 millimeter, we would generally recommend this procedure as a component, but it is individualized to an individual, so I can't make specific recommendations right now. Oh, only about 85% of the time were we able to find a lymph node if we use the blue dye alone. So there are techniques that we now use called preoperative lymphoscintigraphy and intraoperative use of the gamma probe that from a surgical perspective side really help us to reduce the amount of surgery and do it with more targeted precision. The preoperative lymphoscintigraphy is what I call a preoperative roadmap. It's not a cancer test. It's a test that helps us to define where the drainage pathways are. So here's a patient who has a 2.4 millimeter tumor thickness non-ulcerated melanoma of the middle of their back. We would recommend a 2 centimeter margin wide excision generally, as well as lymphatic mapping and sentinel node biopsy. In the top left panel A, the long arrow points to a dark spot, which represents the area where the radioactive tracer was injected into the dermis around the biopsy site. Anything that's dark here is radioactivity. And you can see in panel A, a short black and white arrow. Those represent, since this view is someone looking at us, the left and the right axilla in reverse. In the armpit area, you could see some black spots. Those represent likely lymph nodes that are receiving the direct drainage of the radioactive tracer. In panel B, this is a view from the back. So the spot that we've injected around the melanoma site on the back is more intense. And you could see almost a band-like channel projection towards the white arrow and the black arrow. And those represent the left and right axilla or armpit areas corresponding to the first panel. And from the side views below, you can also appreciate this drainage pathway. We can actually identify then to which of the nodal basins the melanoma drains. And here, if I take you into the operating room for a minute, on the top left panel is what we call a picture of a gamma probe. It's essentially a fancy Geiger counter on a leash, if you will. And after injection of the radioactive tracer, as well as a blue dye, before the surgery, we can transcutaneously through the skin, that is, localize where the uptake is. And then just below on the left, you could make out a blue stained lymph node where the radioactive tracer has channeled us to, often co-localizes with the blue dye. We could then rescan the basin and remove any additional sentinel lymph nodes that either have blue stain or are radioactive or both. And then those are the sentinel nodes that would get submitted to pathology. Here's a close-up view of the lymphatic vessel leading to the blue stain lymph node. The entire incision is just about 1.5 inches, and so significantly smaller than a lymph node dissection or formal removal of the compartment of lymph nodes might be. And then from a staging perspective, not to dwell on the details, but for an individual whose lymph nodes contain no evidence of melanoma, one of the 8 T categories would be identified based on the tumor thickness and the ulceration status, and the pathologic stage group then on the right would be noted. And that will be used for treatment decision-making as well. Well, what if a sentinel node contains a microscopic metastasis? Well, we used to recommend formal lymph node dissection or removal of the whole compartment of lymph nodes where that sentinel node was identified. And I don't have time to go over the clinical trial data that was now published a few years ago that we participated in. But instead now of completion lymph node dissection as a routine, over the last few years, there's been a dramatic evolution now in terms of how we manage the nodal basin for someone with a positive sentinel node, where we now generally actively surveil that lymph node basin rather than recommend completion lymph node dissection for the vast majority of patients. Now, we've talked about patients who might have either involvement or no involvement in their sentinel nodes. There's also other types of regional melanoma metastasis that are important for staging and for treatment. And these are individuals who, by palpation, have a lymph node that's identified, or by imaging exam, have a lymph node identified. And in the center panel is the cross-section of about a 2-inch lymph node, and showing the pigment of the melanoma in that lymph node at the time of surgery as an example. Complete resection of the nodal basin has been a standard approach for regional lymph node disease, but as Dr. Amario will likely highlight, the approach of using upfront systemic therapy called neoadjuvant therapy as an adjunct to our overall treatment plan, we're now really trying to evolve how much surgery is actually required depending on the response to therapy. And then on the right is an example of what we call satellite or in-transit disease. Think of these as melanoma cells that have escaped the primary site, in this case on the heel, and are making their way to the lymph node basin, but haven't quite gotten there yet. They're in transit on their way, or a satellite around the primary site. And these can be sometimes amenable to surgery and other kinds of intralesional or systemic treatments, but they can also sometimes be very challenging to manage. This is a very complex grid here, but I just wanted to highlight for part of the staging system involves an assessment of the N category, whether there's regional disease based on the number of regional nodes and whether there's any in-transit satellite, or if it's only microscopic satellite disease, microsatellite metastases. And there's an N1, an N2, and an N3 categorization of that. There are stage groups that we as clinicians will then use. On the left, a little bit difficult to identify, but we developed a staging grid that's really easy to use. So in this example of a patient with a 1.4 millimeter non-ulcerated melanoma that we would classify as T2A and had 1 out of 3 sentinel lymph nodes involved, you would look at the schema, it would correspond to N1A. This would correspond to an individual with stage 3A melanoma, and then we can use that information for treatment decision-making. And we're constantly trying to improve the information beyond staging with other approaches, some of which are funded by MRF advocated funds through the DoD. So taken together, the stages 1, 2, and 3 stage groups are outlined here in terms of the likelihood of survival. Very, very high survival rates for melanoma that's detected early. Can't emphasize enough the importance of screening and surveillance, particularly if you've had a melanoma in the past. The skin is a big organ, so one is at risk for additional primary melanomas. And so talk to your treatment team about that to see if that's an appropriate strategy for you too. And on the right are for patients with stage 3 disease, a lot of heterogeneity in prognosis, and these curves are all moving up, as Dr. McQuaid noted, as we have been advancing the field as a global melanoma community. And then finally, to round out this presentation, patients with distant metastasis, or M category, are classified by the anatomic site, whether it's to the distant skin, soft tissue, or distant lymph nodes, the lung for M1B, M1C, to visceral sites that are not yet in the central nervous system, and M1D, the central nervous system, with an additional stratification of whether the lactate dehydrogenase or LDH level is elevated, or not help to round out how we stage patients. And these features are often used for clinical trial stratification and eligibility as well. And with that, I thank you for your attention.
Thank you so much, Dr. Gershenwald. And do you want to tell us what what those pictures are that you were showing at the end?
Sure. So COVID has been my veggie garden, or my wife and my veggie garden has been a recipient of additional TLC during the last 2 years of COVID. So here's just a small array of some of the produce that has helped sustain us when the pickings were often thin at the market. So looking forward to sharing these stories too in the clinic. Many of my patients are gardeners, and I think sometimes talk too much about my gardening when we're sharing updates, and I always learn as well about some new tricks of the trade, and maybe even shed off a little bit of interest in gardening for those who say they don't know how to grow anything. Anybody can do it.
Awesome. So we'll take one question from the question and answer, and then I have a question as well. So Francis Teeter is asking, can you talk about how we actually diagnose and stage 4 melanoma?
Sure. So I don't think there's one simple answer here, but in general, the concern for stage 4 can be related to symptoms that might lead the clinical team to a physical exam, and some imaging. Comprehensive imaging for patients with advanced disease would be typical, either with a CT scan of the chest, abdomen, and pelvis, and an MRI of the brain, or sometimes use of a PET CT scan. And when there are concerning findings, a decision is then made about which, if any, to biopsy to confirm a diagnosis. And if distant disease is identified and confirmed, that's how we would confirm a diagnosis of stage 4 disease. And that's often an important consideration for assessment for patients with regional disease, because we know that there's a risk of additional spread to distant sites. And so for those of you who may have stage 3 disease, staging was likely a component of that to confirm that we're strategizing on just a regional issue at the moment, and not also on something that might be distant in nature. Management is then considered based on the extent of the disease, where surgery can have an appropriate part of the strategy in some cases.
Great, thank you. And then my question, Dr. Gershenwald, is many of us, so many of our, as you said, our cancer survivors, our melanoma survivors, are also at risk for second or even third or further melanomas or non-melanoma skin cancers. When is it appropriate to have a shave biopsy of a suspicious lesion? Because you did talk about how, you know, the biopsy really impacts the future surgical management. And my second question is actually, if we have a diagnosis of melanoma, when would Mohs surgery be appropriate?
Sure. So the first one, when to use a shave biopsy, I think that it's not a black and white answer. It's a bit challenging. As practitioners who specialize in the care of patients with melanoma, we see the numerator, if you will, of individuals who have had a biopsy and it was a melanoma. But if we think about the broad array of biopsies that are performed in general by primary care providers or dermatologists, the vast majority of those biopsies are not melanoma. And so at one level, shave biopsy is easy to perform. It's quick for the patient and it's quicker for the provider, because there are usually no sutures involved. There's a topical dressing and then it heals over time. The challenge, as Dr. McQuaid and I think in going over the sample pathology report alluded to, is if there's an incomplete excision of the biopsy, of the suspicious lesion from a shave biopsy, and the base of the lesion is not completely encircled by the shave biopsy, we might underestimate the true depth of the disease. And so in some cases, we don't have the best available information and we just have to make do with that. So what I would say is that if a biopsy is being concerned, it's completely appropriate to talk to your provider about the type of biopsy, just like we started the discussion with 15, 20 minutes ago, and ask about the appropriateness of the biopsy technique. That being said, not all shave biopsies are bad. The American Academy of Dermatology, if I'm not mistaken, recommends that if a shave biopsy is to be performed, it's called a deep saucerization shave biopsy, which would mean that it would get underneath the dermis into the fatty tissue. And so if there's a complete excision of a full thickness of the skin, we get that critical diagnostic information. It doesn't mean that we can't manage things if a shave biopsy incompletely excises, but there's sometimes a gray zone that we may need to compromise in the best data that we might have available. And then the other question was related to the use of Mohs surgery. So Mohs is a technique of a dermatologic surgical technique of essentially a layered approach to removal of tissue. In general, for invasive melanoma, that's not recommended. There are some rare exceptions, at least in our broad practice here, for certain types of non-invasive or in situ melanomas, particularly in very anatomically and functionally sensitive areas like on the face. A Mohs type approach could at times be considered in the context of a multidisciplinary discussion to consider preservation of function and such. But in general, Mohs is not recommended for routine care. It doesn't mean that a Mohs trained surgeon can't perform an excision similar to what I had demonstrated, but it doesn't mean that the Mohs technique is necessarily appropriate in the vast majority of melanomas that we treat.
Great, thank you, Dr. Gershenwald. Okay, so we'll move on to our next speaker. Again, you can continue to put questions for Dr. Gershenwald in the Q&A. Our next speaker is actually going to be Dr. Rhoda Amaria. This will actually be a recorded presentation as she's giving another concurrent presentation this morning. Dr. Amaria is actually an associate professor in melanoma medical oncology at MD Anderson. She is going to be speaking about adjuvant and neoadjuvant therapy in melanoma. So Dr. Gershenwald mentioned that for stage 1 and stage 2, the primary treatment is surgery. For stage 4, our primary treatment is going to be systemic therapy. And where we really come together as surgeons and medical oncologists is in our patients with stage 3 disease, where we're really combining doing surgery as well as systemic therapy. Dr. Amaria actually leads the multidisciplinary conference that Dr. Gershenwald alluded to. And this is where we have surgical oncologists, melanoma medical oncologists, radiation oncologists, pathologists, and radiologists all come together to actually review specific cases that need multidisciplinary care. So Dr. Amaria runs that conference. She also runs our neoadjuvant protocols, and she'll of course speak more about that and what that actually means. And finally, she also runs our TIL program, tumor infiltrating lymphocyte therapy. And I do see that we have one participant today who has actually benefited from that treatment. So again, Dr. Amaria will be via a recorded presentation. However, she has put her email there for questions. I will also say, though, that all of our panelists here are also able to address and answer questions about adjuvant and neoadjuvant therapy. And so again, please put those questions in the Q&A.
Good morning. I'm Rhoda Amaria from MD Anderson. It's my honor to be here today to discuss adjuvant and neoadjuvant therapy in melanoma. Here's a listing of the companies where I get clinical trial support, as well as my consultancy obligations. So I think the best way to start this off is by getting some definitions. So we'll start with adjuvant therapy and look at this specific case. So here we have a 37-year-old man. He presents to his dermatologist with this concerning skin finding on the arm, but no other concerning clinical exam findings. So he undergoes a biopsy and it shows a 4.75 millimeter thick melanoma. This is by definition a high-risk primary melanoma, so he proceeds with surgery. We review the pathology, and he likely gets scans of the body, including CT scans or MRI of the brain, because this kind of melanoma does have a risk of distant metastases. Assuming there's no evidence of distant metastases on the scans, and he just has a skin melanoma, we would then discuss adjuvant or post-operative therapy. So if we look in a little bit more detail about the staging system of melanoma, we know that stage 1 melanoma patients do the best, have the best prognosis as shown here with 10-year survival about 95%. Stage 2 melanoma patients, which are patients that just have thicker, more scary looking melanomas, are okay, 10-year survival 84%. And then stage 3 melanoma patients have the biggest risk. These people have both skin melanomas as well as spread into the adjacent lymph nodes. And if we look at a little bit more detail in the stage 2 and stage 3 populations, there are these different subcategories that help us to better define people at the highest risk. And what you can see is that the stage 2B and 2C patients actually have worse survival than patients with stage 3A melanoma. And until recently, we really had no good post-operative medical therapy for these high-risk stage 2B and 2C melanomas. And that was until a couple months ago. And so this is in a very important clinical trial that was recently presented. And it took patients with surgically removed stage 2B and 2C melanoma. Half of them are randomized to a placebo and half of them are randomized to a drug called Pembrolizumab, which is an immune stimulator. The goal of the clinical trial was to define how long patients could go without having new disease. That's called recurrence-free survival. And what we see here is that this green line represents the patients who received Pembrolizumab, and they did better than those patients that received the placebo. And in fact, using the Pembrolizumab lowered the risk of recurrence by about 39%. Additionally, this drug is overall very safe, with about a 10% severe side effect rate, but most patients did very well on this medication. And based on this preliminary data, this is now an FDA approved option for patients with resected stage 2B and 2C melanoma. And this is really just hot off the presses in the last couple months. Now, we have had good data on using either adjuvant nivolumab or pembrolizumab for patients with stage 3 melanoma, which I'll remind you are patients with melanoma of the skin as well as adjacent lymph nodes. So in this specific clinical trial, they took a slightly higher risk patient population, stage 3B, C, and even resected stage 4 melanoma patients. And half of them got this drug called nivolumab, and half of them got a different immune stimulator called ipilimumab. And again, looked at the chance of having no recurrence or preventing recurrence. And what we see is that use of the nivolumab lowered the risk of recurrence versus the ipilimumab, and that the medication was overall safe. And a very similar clinical trial was done using pembrolizumab. Instead of using an active control, they used a placebo, and half of them got placebo, half of them got pembrolizumab. And again, what we see here is that the use of the pembrolizumab outperformed the placebo and lowered the risk of recurrence, and again, was pretty safe medication. Now, what's important to note here is that this group, this study used a slightly lower risk patient population, resected stage 3A to 3C. And what's important is that the stage 3A patients had to have enough disease to qualify. So specifically, the criteria is that if there was only one lymph node, the melanoma deposit had to be at least 1 millimeter. The reason why is because 1 millimeter in a lymph node is determined to be higher risk disease than people that have only isolated cells of melanoma. And so if you have a diagnosis of stage 3A melanoma, it's not uniform that you will be offered post-operative therapy because, again, that group of patients has low risk disease. There's one other important clinical study to discuss in patients with resected stage 3 melanoma, and this is for patients that have a Braf mutation, which is basically a change in the DNA that allows this specific cell to acquire features associated with being a cancer. So that's a Braf mutation. And about 40% of patients with skin melanomas have this Braf mutation, so it's a pretty common thing. So people that had this BRAF mutation were eligible for this clinical trial where they received either placebo or 2 pills called dabrafenib trametinib for a year period of time. And again, looking for recurrence-free survival. And what we see is the patients here who got the dabrafenib trametinib did significantly better than the placebo and lowered the risk of recurrence by about 49%. Additionally, this medication group is very safe and it's used widely both in stage 3 melanoma as well as in stage 4 melanoma. So to summarize where we are with adjuvant therapy, the real new exciting information is that pembrolizumab has been FDA approved for stage 2B and 2C melanoma patients, simply because, again, we know that this group of patients has even a higher risk than stage 3A patients. We have use of both nivolumab and pembrolizumab for resected stage 3 disease. And we also have dabrafenib and trametinib for resected stage 3 patients with a BRAF mutation. Now, in patients that have a BRAF mutation, we really have no data to suggest that either the pembrolizumab or nivolumab is better or worse or the same than using the dabrafenib and trametinib. So this is really an individual discussion with your patient and with your doctor to discuss side effect profile of the two different types of drugs in detail, as well as the logistics of how the medications are provided. But there's really no head-to-head data to say that one regimen is better than the other in this setting. So now we're going to switch gears and talk about neoadjuvant therapy. So if we go back to a case, a 37-year-old man has a newly diagnosed melanoma of the temple as circled here in black. And what you can see also in the neck is a swollen lymph node. And so this patient has a needle biopsy of the swollen lymph node, and that shows melanoma. So in this situation, this is a patient with what we call clinical stage 3 melanoma. So anytime you have a lymph node that you can feel, that's a diagnosis of clinical stage 3 melanoma at least. So in this situation, we have two approaches. We could do what we just discussed, have surgery and then adjuvant or postoperative therapy. But these patients with clinical stage 3 melanoma do have a high risk of recurrence with this kind of an approach. So in this situation, we would often consider neoadjuvant or preoperative therapy, followed by surgery and then adjuvant or postoperative therapy. Now, why would we do this? Well, there are some significant advantages of a neoadjuvant approach. Specifically, if our neoadjuvant therapy shrinks, we could potentially we could potentially shrink down the size of the tumor prior to surgery and potentially make surgery a little bit easier. In people that have clinical stage 3 melanoma, as I said, this is a high-risk disease category. These patients have probably had disease growing for a while. So sometimes starting the therapy earlier will hopefully prevent distant spread of disease. Additionally, we can really personalize therapy depending on response. So if patients have an excellent response to neoadjuvant treatment, maybe we don't have to change the adjuvant therapy, or maybe they don't need adjuvant therapy at all. However, if they don't have a great response to the neoadjuvant therapy, we could potentially change the postoperative therapy depending on the neoadjuvant response. Additionally, we have some data that I'm going to show you in a few slides that people that have a pathologic complete response, basically meaning that they get the neoadjuvant therapy and the tumor is all dead at the time of surgery, well, we know those patients have improved outcomes altogether. But there are some disadvantages, of course, and so if we give neoadjuvant therapy and patients have bad side effects, this could potentially delay or even prevent surgery. Additionally, there are some people that just have, unfortunately, really aggressive disease, and their melanoma could grow despite the neoadjuvant therapy, which is always something we never want to see. So let's talk about neoadjuvant therapy again and look at a case. So this is a patient of mine, 60-year-old guy, completely healthy, and he developed a protruding lymph node out of his neck over a 6-week period of time. He had a biopsy showing melanoma. He had scans that showed no other evidence of disease. And he decided to participate on a clinical trial we were offering at MD Anderson using nivolumab with an experimental drug called relatlimab. And he had a great response. He had 2 doses of therapy, which is what we use in the neoadjuvant setting. This was the disease in the neck, circled here in red. And then after the doses of therapy, you can see that the lymph node really shrunk down and was starting to disintegrate based on scans. He ended up having surgery and he had a complete pathologic response, meaning all the melanoma was dead, and he's doing great over 2 years after surgery. Now, this is a case to demonstrate that right now, neoadjuvant therapy in melanoma is experimental. This is something that we require, or we highly recommend enrollment on clinical trials, because otherwise it's really not technically an FDA approved regimen at this point. And at MD Anderson, we've been really at the forefront of doing these clinical trials along with some other centers across the world. And we've developed what we call the International Neoadjuvant Melanoma Consortium, which is a group of people really interested in bringing neoadjuvant therapy into a standard of care in melanoma. And we were able to pool the data on some of our early clinical trials. And we've shown that here in blue are the patients that get the pathologic complete response from these various different clinical trials that we've used. And you can see that those patients that are getting the pathologic complete response are doing significantly better. And that's what we're trying to do, is design regimens that have a high pathologic complete response rate, because we know that those patients are going to have better outcomes long term. So to summarize where we are with neoadjuvant therapy, right now it's experimental, and we highly encourage enrollment on clinical trials. This is really an opportunity to help improve outcomes in patients that have, honestly, a high-risk disease with this kind of clinical stage 3 melanoma. Neoadjuvant therapy is really a team sport. This really requires early collaboration between the surgeon, the medical oncologist, radiation oncologist, if we're thinking about radiation, and of course the pathologist to review the surgical specimen. And again, as I just said, the goal is to try to design regimens that are, of course, well tolerated, but also effective and produce a pathologic complete response. Thank you so much for your attention today. I hope you learned something from this presentation. It's been my honor to be here today. Thank you so much.
Great. Okay. So as I said, you're welcome to put questions related to Dr. Amaria's presentation in the Q&A. Our other speakers will be able to address them. So next, it's my pleasure to introduce Dr. Mike Davis. Mike Davis is a professor of melanoma medical oncology at MD Anderson, and he is also actually the chair of our department. Today he's going to be speaking about targeted therapy in melanoma. Dr. Davis actually was one of the key international leaders on the clinical trials that led to the FDA approval of targeted therapy regimens. He also runs a lab that is specifically looking at mechanisms of resistance to targeted therapy and how we can better design targeted therapy regimens to overcome that resistance. We will also, Dr. Glitza will be speaking about brain metastasis later, but I will also note that both Dr. Davis as well as Dr. Tabi, who will be speaking next, also see patients within our brain mets clinic and are specifically focused on brain metastases as well. So go ahead, Dr. Davis.
Great, thank you so much. Well, as Jennifer said, again, sorry that we can't see you all in person and hang out at the coffee break and talk, and it's really great to see how many people are here today. I apologize. I think my welcome messages just went to the panelists instead of everyone, and certainly really nice to see some of my own patients here. Would also just again like to thank the Melanoma Research Foundation for their support. As she mentioned, one of the things that the MRF has helped to do is really facilitate research. And as she mentioned and Jennifer mentioned, one of our big challenges is brain metastasis. And I was one of the people who was able to participate in that meeting that we had just a couple months ago that was able to bring together people from all over the country to talk about how to really advance research and improve outcomes in that area. But today, as Jennifer said, it's really my pleasure to talk to you about targeted therapy. So let me go ahead and share my screen. Go here and then go into presentation mode. Very good. So good morning. So I'm going to talk to you about targeted therapy. And again, when we start these talks, we do have our disclosures As Jennifer mentioned, I run a laboratory. I do lots of research of how to make targeted therapy work better, how to make immunotherapy work better. And so we work with lots of different companies because we're trying to do research that really will impact patients, but don't think any of that will impact what I'm going to talk to you about today. And in order to explain targeted therapy, I actually find it's useful first to sort of talk about the history of chemotherapy, because that's really what targeted therapy in many ways is replacing in the treatment of melanoma. And so one of the interesting things is that the story of chemotherapy really goes back to World War I, and particularly soldiers who were exposed to nitrogen mustard gas in World War I when they came back from the war often started getting these very unusual opportunistic infections. And the reason that was happening was because we found out that the chemotherapy had destroyed the bone marrow, the part of our body that makes our white blood cells. And so these patients, again, were sort of like fully immunocompromised, almost like full-blown AIDS patients. And so a lot of research went into how do you treat infections in patients without sort of a functioning immune system. But for oncologists who are taking care of cancer patients, particularly cancer of the white blood cells, this was actually the first hint that chemicals could actually be used to kill white blood cells, and particularly leukemias or lymphomas. And so one of the people who led many of the investigations was Dr. Sidney Farber, who's shown to the right, for whom the Dana-Farber Cancer Institute is named. And indeed, it was in 1946 that Dr. Farber reported the first successful systemic treatment of a patient with cancer with chemotherapy. And so between the 1950s to the 1980s, we developed most of the standard chemotherapies that are used in the treatment of many different types of cancers. And the reason I sort of emphasize this timeline is it's because really at the very end of that period, in 1977, did we actually identify the first oncogene, which is a gene that when it's abnormal, turns a normal cell into a cancer cell. And so really, all of the chemotherapies that we developed and used quite widely for a long time were actually developed before we know what actually drives cancer cells. And so really, since 1970s, really through today, many researchers have been working to identify what are those changes that happen specifically in the cancer cells that turn a normal cell into a cancer cell. And what targeted therapy does is leverage that information. So now instead of coming in with chemical warfare, which is really what chemotherapy is can we come in with smart bombs, targeted therapies that really go after those things that are only happening in the cancer cells, and particularly the things that are most important for a cancer cell to thrive and survive. And so that's really what targeted therapy is. So why do we think about targeted therapy for melanoma? And so really there's sort of two key facts that really made us think that this would be a strategy to pursue. First, when we've analyzed the DNA from different tumors, looking at the numbers of mutations and types of mutations that happen, one of the first sort of take-home messages is that melanoma overall, on average, has more mutations than any other cancer type. We actually, when we do DNA sequencing on a melanoma tumor cell, looking at all of the DNA there compared to the normal cells in the patient, we actually find thousands and thousands of mutations. And this is really due to the fact that ultraviolet radiation from the sun is one of the factors that is really best at causing DNA mutations. And since melanocytes that give rise to melanoma absorb ultraviolet radiation, we're starting from cells that are accumulating lots of DNA damage. Now, for us, our problem then isn't actually finding mutations, it's finding mutations that are clinically significant and really ones that are important to inhibit. And one of the things that's been so gratifying is that in patients with cutaneous melanoma, almost 70% of those patients, we can identify genes that are activated by mutations that are potentially therapeutically targetable. And so this means that we have the targets. Can we now convert that into new therapies? I will say that although that percentage is very high for cutaneous melanomas or melanomas of the skin, the percentage is lower for mucosal melanomas that start inside the body and uveal melanomas that start in the eye. But I'll talk about that a little bit later. And so as you heard, Dr. Gershenwald is again one of the international leaders, not only in clinical research for melanoma, but also helped to lead the melanoma TCGA effort, where we did a large effort to really globally characterize close to 400 melanoma lesions to define what are the mutations that happen in this cancer, what are the RNA changes, what are the DNA methylation changes. And the take-home message that we had from this is that when we studied cutaneous melanomas, as I said, almost 70% of those tumors had a mutation that turns on a pathway called the RAS-RAF MAP kinase signaling pathway. And in particular, almost 50% of the cutaneous melanomas have a mutation in a gene called BRAF. These mutations were actually discovered back in 2001 by Dr. Andy Futriol, who's the department chair of the Department of Genomic Medicine here at MD Anderson. And so this in some way validated his finding. And we knew that that mutation would activate this pathway. What this sort of filled out is that even when that mutation isn't there, most melanomas have some type of change in this pathway that will activate it, and therefore suggested that maybe bringing in inhibitors against this pathway would be important. Now, when we talk about the BRAF mutation, there's a couple of things I think that are good to understand about these mutations. So we haven't talked about it too much, but again, we know that melanomas can start in different places. And again, conventionally, when we say melanoma, we mean melanoma of the skin or cutaneous melanoma, and that's where 40 to 50% of these tumors will have this BRAF V600 mutation. We also have melanomas in areas of skin that are relatively sun protected. We call these acryl melanomas on the palms of the hand, the soles of the feet, or under the nail beds. And there we do find these mutations, but at a lower rate, probably in the 10 to 20% range. There are also mucosal melanomas that start on mucosal surfaces inside the body, particularly in the oropharynx and the GI tract and in the reproductive tract. So there's no sunshine whatsoever. And here the rate of BRAF mutations is much lower, probably in the 5% range. And then finally, those uveal melanomas that start in the eye, by definition, have a 0% chance of having one of these BRAF mutations. One of the questions I often get asked by patients is if we do biopsies of different tumors, will some have the mutation and some not? And in actual fact, one of the interesting things is we've learned these BRAF mutations happen very early in the development of a melanoma. And so when we've done studies where we've tested the primary tumor, a lymph node metastasis, and distant metastasis from the same patient, when we do the BRAF test, they basically match over 99% of the time. So really, it's sufficient for us to really test any one of those tumors to determine whether the BRAF mutation is present or not. Now, the fact that the BRAF mutations were so common in this disease really made it a high priority for us to test this as a target for our targeted therapy strategies. And it's really ended up being sort of a proof of principle, both of the promise of targeted therapy and also some of the limitations of this approach. And so this is actually my first personal experience with these BRAF inhibitors. This is back in 2009, 2010, there was a patient who was admitted to the melanoma inpatient service repeatedly because he had this very large tumor on the right side of his chest. On this PET scan, this large thing here was a large tumor. This was causing bleeding from the axilla. This was causing multiple infections, severe pain. The patient was getting admitted over and over again. This is a CT scan where the patient's lying on his back with his feet towards us, and this tumor is here on the right armpit, is so big, it's actually pushing over his lungs and his heart. And he was one of the first patients that we found had one of these BRAF mutations and qualified for the first clinical trial we had with a new targeted therapy called vemurafenib, which was designed to inhibit this mutated form of BRAF that was present in the tumors, but not in the rest of his body. And so we're very excited when the patient was able to enroll on the tumor, and particularly when he came back to see us 6 weeks later, not because he was being admitted, but because he'd been to his clinic appointment where his PET scan showed that the tumor had almost completely disappeared. And he was now feeling well, he was not having any side effects. And this was, again, really sort of a miracle. And one of the things that we often ran into in targeted therapy trials is every now and then we would see a response like this, but it was really sort of what we would call an unusual responder. It was atypical to see this type of response. And just to put it in perspective, chemotherapy had about a 10% chance of achieving a response like this. But what was the big surprise and what was so exciting is that instead of this being the exception, this is what we commonly see in our patients with a BRAF V600 mutation. So this next slide shows what we call a waterfall plot. So when we do clinical trials, we report out how effective our treatments are in multiple different ways. And one is you'll hear us talk about a response rate. And that means, did the tumor shrink significantly? So on a waterfall plot, what we're plotting here is what was the change in size in the tumor before we started the treatment versus after we did the treatment. And so if the tumor didn't change at all, it would have a bar right here at 0. And if the tumors were growing, the bar goes up. And if the tumors are shrinking, the bar goes down. And so what we saw in this first big phase 3 clinical trial of our first BRAF inhibitor, vemurafenib, is that we said that the clinical response rate for patients with a BRAF V600 mutation was 50%. And that's because we draw this line that you have to have at least 30% tumor shrinkage. But if you just sort of look at this in general, what we really saw was that almost 90% of the patients had at least some degree of tumor shrinkage, again, compared to 5 to 10% with chemotherapy. And this was the data that actually caused this to be the shortest clinical trial that we'd ever conducted in the phase 3 setting in any type of cancer, because of how dramatic the effect was, and led to the approval of vemurafenib for metastatic melanoma patients with this BRAF V600 mutation back in 2011. So that's really the beginning of the targeted therapy era for us. Now, while that was very promising, this quickly became the challenge that although almost all patients will respond to the targeted therapy, unfortunately, most patients will go on to develop resistance. And so this is a patient where on the CT scan, they had these dark things, again, as melanoma in multiple places. They started on the BRAF inhibitor, and after only 2 weeks, almost everything had disappeared. But 4 months later, all the tumors came back. And so when we were using just the one BRAF inhibitor all by itself, we saw, again, 90% of patients would achieve disease control, but 90% of patients had actually developed resistance by 1 year. And so these treatments worked on average for about 6 months. So as Jennifer mentioned, many people then started to try to understand why resistance was developing. And what really became very clear is that the tumors started to outsmart the BRAF inhibitor. So the BRAF mutation was never lost from the tumors. It was still there. But what the tumors did is induce different changes so that even though the mutation was there and we gave the BRAF inhibitor, the tumor figured out a way to turn this RAS-RAF MAP kinase signaling pathway back on. And there's a variety of different ways that it could do it. What we showed in the laboratory is that if we came in and blocked the pathway somewhere further down than BRAF with a second medicine like a MEK inhibitor, we could overcome those resistance mechanisms. And that gave us the rationale to start doing clinical trials in patients to combine 2 different medicines against this pathway together. And so this was the results we saw. This is, again, another one of those waterfall plots for patients with a BRAF V600 mutation. This was the first clinical trial where we combined a BRAF inhibitor with a second medicine called a MEK inhibitor, which, as you can see on this square, is just downstream of BRAF. And, you know, I still remember when they showed this result at one of our large meetings to have gone in just a few short years from 5% response rates or 10% response rates with chemotherapy to 80% response rates and disease control in almost 100% of patients in a very short period of time was absolutely remarkable. And so we rapidly showed in multiple trials that for patients who have a BRAF mutation, it was much more effective to combine a BRAF inhibitor with a MEK inhibitor than giving a BRAF inhibitor alone. And interestingly and unexpectedly, in many ways, giving the 2 medicines together were better tolerated than giving either medicine alone, because their side effects or their side effect mechanisms sort of canceled each other out. And so rapidly, the standard of care for targeted therapy for a patient with a BRAF mutation became using a BRAF and MEK inhibitor together. And we now have 3 FDA-approved combinations. So our first combination was dabrafenib and trametinib, which was approved in 2014. Our second one was vemurafenib and cobimetinib, approved in 2015. And our most recent one, encorafenib and binimetinib, was approved in 2018. Now, how do we pick between these 3? And the first thing when patients ask me we still have never done a head-to-head trial where we compare one of these medicines against the other. So we still can't say definitively which one is the absolute best. However, we do know that there are differences between these regimens, and those differences often help guide us in how we pick which one of these combinations to use. And I don't want to go into this in incredible detail, but just as an example, the dabrafenib-trametinib regimen, which was the first one that was FDA approved, is a regimen that actually is quite convenient in that it actually includes the least number of pills per day, a grand total of 5 pills. And that for people particularly who have trouble swallowing medicines may be a real advantage. On the other hand, having that small number of pills means that patients get side effects. We don't have a lot of flexibility of making dose adjustments to reduce those. And dabrafenib-trametinib is also unique among the combinations in that patients have to be fasting when they take it. They have to keep the trametinib in the refrigerator. And so even though that was our first regimen and one that we built up a lot of very positive experience with, sometimes we use some of our newer regimens. So as an example, the encorafenib-binimetinib regimen is one that has more pills, so it's less convenient, but on the other hand, gives us more flexibility in making dose adjustments, and it doesn't require fasting or refrigeration. And again, this idea of being able to make dose adjustments is because that's one of the ways that we can manage the side effects that happen with targeted therapy. And so what kind of side effects do we see with targeted therapy? So they actually are different depending on which combination. But for example, with dabrafenib-trametinib, almost half of the patients will develop fevers. These are not from having an infection, but it's just an still sort of unexplained reaction that some people can have to these medicines, and usually goes away with just holding the drug and taking antipyretics, and you can resume the medicines. We do see other side effects like nausea and rash, fatigue. We also look out in particular with the MEK inhibitors with problems with eyes, problems with the vision, and we also will monitor cardiac function. One of the important things about these side effects is that, again, usually they can be managed by making adjustments to how many pills you take each day, but also quite importantly, these side effects go away if you actually stop the medicines. These are all reversible. When we have patients who develop a side effect, now we do, again, think about should we adjust the doses of the medicines to manage them, but also now that we've got 3 FDA-approved regimens, we may also try to see which combination is best tolerated, because sometimes it's just a matter that patients will tolerate one regimen better than another one. So we have a lot of flexibility there. Now, as I mentioned, what you'll hear about with immunotherapy that's so remarkable is not only, again, about the chance of it working, but really this track record it's developed of working for years and years and years. And so targeted therapy actually has a higher chance of working initially, but unfortunately, in most patients, it works from about 12 to 15 months on average, and then patients will develop resistance. It's not impossible to actually have very long responses, and across our clinical trials, we now have 5 years of follow-up in most of these studies. About 20% of patients are alive and well and still respond to these medicines 5 years later, but it's difficult for us to actually pick out who those patients are. But it absolutely is possible to do well for a very long time. It's hard for us to know whether we've cured patients because in general, we don't take patients off of these medicines, which is again, another difference versus the immune therapy. But one of the things that I do think is important for people to understand that we talk about with our patients, one of the interesting things we've learned is that in patients who develop resistance to targeted therapy, this is not necessarily permanent. So if we have patients we've treated with targeted therapy and at some point the tumor starts growing again, we usually switch over to other treatments and try those. If those treatments don't work, it actually is possible to try the targeted therapy again, and it may actually work again. And so you will often see if you're a patient who has one of these BRAF mutations, it's not sort of just a one-shot deal. This is something that we may come back to at different points in time if it's needed. Now, we again focus a lot on the BRAF mutations because they're the most common mutation in the cutaneous melanomas, but as I said, they're actually much less common in the other melanoma types. But we do have other mutations that we can find in these tumors, including Nras mutations. And then in the mucosal melanomas and acryl melanomas in particular, mutations in a gene called c-KIT. And then for uveal melanoma, we now know that 80% of these tumors have mutations in two genes called GNAQ and GNA11. And these are genes that can indicate new treatments that may actually work for you. And so in particular, for patients with KIT mutations, these are mutations that have been identified in other cancers, and that led to the development of several c-KIT inhibitors. These, again, like BRAF, are medicines that are taken once or twice a day, and we can see very dramatic responses if the tumor has one of the common KIT mutations. We do also know that for Nras mutations, that although there's no FDA-approved inhibitors, we actually have many clinical trials designed specifically for patients with Nras mutations. And we do actually rarely have some atypical BRAF mutations that also can respond to some of our MEK inhibitors or for which there are clinical trials. And so because of this, one of the first things that we do when we see patients here at MD Anderson who've been diagnosed with stage 4 disease is make sure that patients have had their tumor tested for these types of mutations so we know what type of treatment options we have. Even if we're going to start with immune therapy, knowing what other options there are becomes very important. So molecular testing is something that we ensure happens for all of our patients. And here at MD Anderson, when we do that, we're usually testing for somewhere, depending on the patient, between 50 to 200 genes to try to identify what the treatment options are for patients. So just to summarize again, targeted therapy is, again, a personalized treatment approach based on the mutations that we find in your cancer. For patients who have the BRAF V600 mutation that's present in about 50% of cutaneous melanomas, we have multiple targeted therapy regimens that can be very effective, but we're still trying to work on figuring out how can we make them effective even longer to prevent and overcome resistance. These are medicines that can work before immunotherapy or after immunotherapy, and as I mentioned, are medicines that even if you develop resistance can be reused potentially and work again in the future. And again, one of the take-home messages that we just have for all of our patients that when they are diagnosed with metastatic melanoma is to make sure your doctors perform molecular testing so we can actually figure out if targeted therapies are an option for you. So with that, again, it's a pleasure to be here with you today and to be happy to answer any questions that you have.
Excellent. Thank you so much, Mike. There's one, so there was one question in the chat and the question and answer about, do any of the clinical trials look promising for Nras mutations right now?
Yeah, so it's a really good question. And, you know, it's one of the things that Raft mutations happen in many different types of cancers. And so there's many trials that are ongoing. We here at MD Anderson right now have 2 different clinical trials going on with targeted therapies for our patients with Nras mutations and other trials that are going on in our phase 1 department. What these trials usually do is they include one medicine that blocks that MAP kinase pathway that I was showing you at the beginning, but we've learned that RAS can activate multiple pathways at the same time, so we're usually adding something to that. So there are multiple sort of trials that are going on. We can't say right now that we know one is better than the others, but it is also a fast-moving area where there's new trials that come up multiple different times. So if you have an Nras mutation and immunotherapy hasn't worked or wasn't tolerated, targeted therapy clinical trials may definitely be worth looking into.
And similarly, Mike, could you also kind of talk about what is the future and trials ongoing in the BRAF mutation space?
Yeah, so a couple of different things that are going on there. So in the same way that we showed that if we added the MEK inhibitor to the BRAF inhibitor, that was better than the BRAF inhibitor alone, it's made us wonder what happens if we hit something else in that pathway. And so there's new medicines that target the third kinase down there called ERK or MAP kinase. I think that's one of the primary approaches. Dr. Tabi has actually led clinical trials combining targeted therapy and immunotherapy together to see if that will get us longer responses. And that's something that we can talk about more potentially in the discussion part if we'd like to. But the other thing that we're doing is learning new things, like when melanoma goes to the brain, there may be new things that get turned on that we may need to block. So lots of different things lots of different strategies that we're trying. Again, None of them yet that we know is better. So right now, still the standard is BRAF plus MEC, but lots of different trials that are ongoing.
Great, thank you, Mike. Okay, so switching gears now to our other pillar of systemic treatment of melanoma, which is immunotherapy and specifically immune checkpoint inhibitors. It's my pleasure to welcome Dr. Hussein Tambi, who is a professor in melanoma medical oncology, to speak on this topic. So Dr. Tambi, as I mentioned, also works with Dr. Davis and Dr. Glitza in our brain mets clinic. Dr. Tambi is also the deputy chair of our department, and then really actually oversees kind of our overall global trial portfolio together with someone who is in the background today, Dr. Elizabeth, sorry, not doctor, but Elizabeth Burton, who was instrumental in designing this program today, but also works directly with Dr. Tambi in kind of overseeing our overall research program. So Dr. Tambi will be speaking about immunotherapy. So some of the data around already approved regimens, but also around some upcoming, hopefully approvals that Dr. Tambi actually helped lead internationally.
Thank you so much, Jen, for the introduction. You guys hear me okay and can see my slides?
Yes, we can, doctor.
Okay, wonderful. Well, thank you so much for the opportunity to talk this morning. And again, many thanks to the MRF for putting this together and for kind of unwavering commitment really to patient care and to patients and their caregivers and to research. And so as you've heard from my colleagues today, we've come a long way in melanoma, and I think we have a lot more to learn. So I'm going to kind of take a deeper dive on immunotherapy, and as you heard from Dr. Amarian, you'll hear a little later from Dr. Glitza a little bit more specific applications of that. And so again, it's been a long way coming, but finally in melanoma, we have done very, very well in the last 10 years or so. You've heard about targeted therapy, drug development, as you've seen from Dr. Davis, that we have these, the drugs that are in red are the targeted therapies that have been approved over the years. And then in blue, the immunotherapies that have been approved, and I'll go over that. But what's really amazing is 10 years ago, we started with a 5-year survival of less than 5%, and now we have 6-year survival that is over 50%. And so I'm going to try to spend some time kind of discussing with you how this transformation has happened, and really kind of how immunotherapy has come to the forefront as one of our most effective and durable therapies. Well, to be clear, I think checkpoint inhibitors are going to be some of the things I'll talk about a lot more deeply. They're the more kind of widely known therapies that are available. But the fact is, we have known that T cells are quite powerful. T cells are the parts of your immune system that are capable of killing cancer cells. And we have, as you know, in oncology, have tried many, many different ways of activating those T cells, of pushing them to kill cancer cells, and actually have faced some success. I would say interleukin-2 is probably the first success in the history of cancer in which T cells have been activated by a drug and have led to patients doing better. And so Dr. Davis explained to you what a waterfall plot curve is. I'll kind of go a little bit over what a survival curve is, because I have a lot of those and we love them in oncology because they really kind of represent to us what our patients kind of do. And a survival curve has time on the x-axis. So we start at time 0 where all of our patients are alive. So that's 100% at the top. On the y curve, on the y-axis is the kind of the number of patients or the percentage of patients. And as time moves forwards, when we're looking at an overall survival curve, every time we lose a patient, the curve drops. And that's kind of what we measure over time, how many of our patients are still alive and well. And you can see, as Dr. Davis mentioned, for interleukin-2, that tail at the end of the curve, that fact that you go from about 2 to 3 years here, 24 to 36 months, and then all the way to 10 years later, those patients are alive and nothing happened. That curve doesn't drop. That means those patients are doing well. Those patients are actually, we consider them cured. And that is what interleukin-2 had managed to do for patients, and kind of proof of concept that if you get to activate the T cell, you actually can get patients to do well. And you see on the right that if you look more closely at patients that had a complete response, meaning their tumors completely went away, do a whole lot better in general. So the idea that we could do this is very important. The problem with interleukin-2, and that's one of the reasons that it was hard to be kind of widely applicable, is that it's actually a very tough treatment, highly toxic, can only be delivered in the setting of actually almost ICU care settings, and honestly kind of had to choose our patients to be essentially the proverbial marathon runner that be able to kind of manage such an assault on their system, or their blood pressures fall down, their heart rate goes up. It was really, really hard to deliver this. So it was a select group of patients that we could cure with this. So, you know, to go a little deeper on kind of how this whole kind of immunotherapy with checkpoint inhibitors evolved, we'll have to discuss the cancer immunity cycle. And it's a very important aspect here. How are T cells generated, and how do they actually find out a way to go and kill the cancer cell? And it kind of starts with identifying where is the cancer and how is the cancer different from the rest of your system, and finding those antigens that are kind of the markers of foreignness of the tumor that then the T cells can identify. They get activated by dendritic cells, and then they go and kill tumors. So I'm going to attempt something really hard because I'm usually technologically challenged, but I think it would be worth doing because I found this interesting. Can you see this animation now?
Yes, we can, doctor.
It's a really cool animation. I'll credit Roche for doing this, but this is actually exactly what happens. Here's your cancer cell, and it's actually releasing these round spheres, red spheres, that are actually these specific parts of it that are different than your own body, the foreign parts. So we have these specialized cells called antigen presenting cells or dendritic cells that actually identify these foreign antigens and actually captures them, package them, and show them to T cells. So your T cells are these blue cells that initially come, literally we call them naive before they actually talk to the dendritic cell. The dendritic cell tells them, here's the antigen that you need to go recognize and kill. And so these T cells multiply, they become really, really powerful, multiply, and they actually traverse, go through the blood vessels and go and actually seek out the tumor. They follow things we call chemokines. As they kind of actually talk to each other, they use cytokines. Interleukin-2 is one of those. And when they get to the blood vessel around the tumor site, they actually traverse through the kind of the junctions between the blood vessels and actually go out and look at that red sphere. They find that red sphere, they find that antigen, they recognize it through something called the T cell receptor, and then they actually attack and kill that cancer cell. And that's how the cancer immunity cycle works. And as you kill those cancer cells, the idea would be that you release more antigen, and possibly you would be able to go back and continue this until you eliminate the cancer completely. So that's kind of the idea. And then if you look at how immunotherapy works in different places, so interleukin-2, as I mentioned, is kind of in this area. Interleukin-2 and cytokines were designed to kind of just whip these T cells, make them frenzied, and tell them to go out and kill cancer. So they weren't very specific, and again, they cause a lot of toxicity. The two drugs that have really made the most important difference, I would say, in the last 2 years are anti-CTLA-4 antibodies and anti-PD-1 antibodies. And those actually required a completely different way of thinking. And credit obviously goes with a Nobel Prize to Dr. Jim Allison for thinking about this. So if you look at this particular situation here at the priming phase, is when that dendritic cell is teaching the T cells what to do. You have that yellow sphere in this depiction where the MHC complex, where like that is presented to the T cell receptor. What Dr. Allison asked is, why are these cytokines not working? We keep, kind of hitting those cells with cytokines, with interleukin, interferon, and they don't work in a lot of people. Is there something that is holding back the T cells from working? And indeed, as he was trying to understand how this interaction works between the T cell receptor and the antigen presenting cell, he found out that there are actually signals that are required to activate the T cell. It's not enough to show that antigen, you actually have to activate it. And then it turned out that there were signals that also inhibit that activation and that priming. And those signals, one of them was CTLA-4 on the surface of T cells. So Dr. Allison invented this antibody, which we'll talk about in a second. And that's really, really important. So I'm going to use a relatively cheeky analogy, but think about your T cell as Superman. It's an absolute, one of the most powerful cells in the body. It's capable of going and killing those T cells once it recognizes them. CTLA-4 or anti-CTLA-4 is almost kind of the yellow sun to Superman, and it actually gives it the power, it gives it the laser vision so it can go and recognize tumor and actually kill it, right? So by doing that and by giving patients these anti-CTLA-4 antibody, what you're looking at here is the survival curve that I consider probably the most iconic in the history of melanoma. I was sitting in the room when this was presented back in 2009. And on the left side, you see for the first time in the history of melanoma, we had a phase 3 trial in which the control arm was finally separate from the intervention arm. And actually, patients were living longer with ipilimumab for the first time in the history of melanoma. And with 4 doses of this drug, you see that tail at the end of the curve, we had started having 20% of our patients live and get cured of melanoma. Now we have over 10 years data that tells us that that is possible. And again, that's 4 doses, and that's for all of our patients. Honestly, it didn't have to be the 30-year-old marathon runner. Actually, I treat my patients that are in their late 80s and early 90s with this medicine and can still cure them, which is really, really important. And on the right, you see another study that was similar in the second-line setting. So going back to PD-1, and so if you look at this graph again, so I told you where CTLA-4 works and how many patients it cures. On the right side, you look at the effector cells. So I told you that that T cell is already powerful, knows what it needs to do, goes and tries to attack the tumor. It's now already in the tumor microenvironment. It's already looking at that yellow sphere. It recognizes that it's ready to kill the tumor, but then the tumor does something interesting and it pushes this thing called the PD-L1 receptor that actually recognizes a PD-1 receptor on the surface of the T cell. Activated T cells have that PD-1 usually so that they don't attack your normal tissue. So going back to our Superman analogy, basically PD-L1 is kryptonite. I mean, literally this T cell comes in ready to kill, ready to actually eliminate the tumor, and the T cell literally says, stop, don't attack me. And literally, we actually say that the T cell is exhausted. We use those exhaustions actually a technical word. These T cells are exhausted. They're sitting there. They're incapable of attacking the tumor. So anti-PD-1 antibodies, and I have to go deep into Superman analogies here, but it turned out that anti-PD-1 antibodies are literally an anti-kryptonite suit. So this is Superman on the left side wearing an anti-kryptonite suit, and by doing that, kryptonite doesn't work on them anymore, and they can destroy the T cell. And that's exactly what happens in those patients. And so this curve, this is Checkmate 067, which is a 6.5-year overall survival data. This is a study that actually compared ipilimumab alone. So the lower curve that you're looking at is the anti-CTLA-4 on its own. The green curve is the anti-PD-1 nivolumab on its own. And the red curve is the combination of the 2 drugs together. And what that curve taught us is first, ipilimumab does what I just told you. 23% of those patients will be alive. Single agent PD-1 is capable of curing about 40%, so 42% if you look at this. Now, I told you these 2 things work at 2 different places. And so the idea that you could really kind of unleash Superman, unleash your T cells with the sun, letting them have the laser vision, and then make them wear their anti-kryptonite suit will actually make them more effective. And true enough, we know that we have a higher response rate with Nivo and Ipi together. And we have a higher survival, about, again, 50% at 6 years, which is where I was mentioning early on that we have a 6-year survival of 50% or more. So we cure almost 50% of patients with this. And in the long-term data, we've actually learned a few things about who actually gets the benefit. It turns out, again, patients that have, you see that curve, the flat curve at the top is what we want. These are our patients that have a complete response or a partial response, and now there's 88% chance of survival at 5 years, which is, quite incredible. Single agent PD-1 does that as well. We know the number of CRs is a little lower, And ipilimumab, as the first drug that ever did that, was also capable of doing it. From the long-term data, we also start being able to peek out who does better with this combination. BRAF mutated patients on the left do better than BRAF wild type when you add the combination. We start looking at things like liver mets, and then you will actually hear from Dr. Glitza a little later that brain metastases have a specific kind of predilection to respond to the combination of ipi-nivo. But at the end, it's not all rosy. We have a kind of a flip side to the situation, or we have the activity, we have the cure rates, but we also do this at the expense of toxicity. So when I was kind of giving you again, when those super T cells are out there, they're frenzied, they're ready to attack the tumor and kill it. Unfortunately, they also are capable of becoming almost too trigger happy and attacking your own normal tissues. And that's where all of the toxicity from this combination comes from. It is from the immune system attacking the skin, so you get a rash. The immune system attacking the liver, people get hepatitis. It's immune-mediated hepatitis, not infectious. You get diarrhea from the immune system attacking the colon, and so on and so forth. And so what we've learned over the years is on the right bottom corner, you see that we actually have a sense of how these happen, at which rate. So you start with the rash first, and then you get probably diarrhea after, and maybe liver toxicity, and then we have some adrenal toxicity. So we kind of learned about what to expect and what the pattern looks like. We also know that different agents do things differently. So IPI is about 30% grade 3-4. We kind of really care about that grade 3-4 the most because it's called, life-threatening or severe. And then nivolumab or single agent has about 20%. In our practice, probably 15 to 20%. But when you combine these two drugs and you get that excellent potency, unfortunately, you also make it too or quite toxic. So 59% in this case, because again, it becomes too trigger happy. So we have a lot of toxicity with this combination, but we still do it because we can actually cure more patients with this. The other thing that I will always kind of put out there is we love these survival curves. We love talking about how we have 50% of our patients alive at 5 years, but we're still losing 50%. We still have this. I use that black box to remind us that that space there is because our patients are still dying of melanoma, and we have to do better. We have to create new therapies that are capable of saving more patients. And so in that same vein, relatlimab is an anti-LAG-3 antibody, so actually very similar to PD-1 on exhausted T cells. It seems to be kind of working around in the same area, was one of the drugs that has been developed in this space, and in combination with nivolumab, seems to be a lot more effective than relatlimab alone, that's for sure, but also potentially better than nivolumab alone. And this is Relativity 047 that was just reported last year at ASCO and just published in the New England Journal now about a month ago. And it's a study in which we tried this new checkpoint inhibitor. So the first checkpoint was IPI or CTLA-4. The second was PD-1. This is LAG-3 compared to single agent nivolumab. And what we've seen is and this is a progression-free survival curve, slightly different than overall survival here. If the tumor grows by more than 20%, that's what the event is, and that's where people where that curve starts dropping. We've actually learned that nivolumab with relatlimab is capable of actually improving this progression-free survival by almost 25%. So 25% improvement. The median progression-free survival is almost double. The 1 year is about the same as IPI and Nivo, where IPI and Nivo together was 49%. This is 47.7%. But what's really remarkable about this and what gets us really excited about it is grade 3-4 toxicities that I depict here was only 18.9%. Remember, we had with IPI and Nivo up to 55, 59%. This is only 18.9%. So that is really cool because if we can really get that benefit with less toxicity, that would be something that we really hope to achieve for our patients. We looked at different things to see if we can pick out, who should be treated and who shouldn't be treated. LAG-3 expression is one way. It didn't seem to matter very much. And if you look at all of this is called a forest plot. If you look at all of the different reasons that may make a patient more likely to have a poor outcome, like a bigger tumor burden, more tumors, or something in the blood we call LDH, or a higher stage of the disease, still it seems like nivo-rela would actually do better than single agent nivolumab, and that's why all these blue dots are on the left of the of this line. And so really exciting stuff, but again, we still have a lot of work to do. So I'm going to share with you some of the issues we're facing. Well, first, I showed you that with IPI and Nivo as the data or the combination that we have the longest, about 55, 57% will respond to treatment, but then we have 45% of patients that don't, and we call those patients having primary or intrinsic resistance. Unfortunately, over time, not everyone that responds does really, really well. So you've seen the survival, but the progression-free survival, meaning that those patients that the tumors grow, is a little lower than overall survival. And so over time, about 50% of patients can acquire resistance. And we call that, again, secondary resistance or acquired resistance. And so as we think about this, we really have to figure out ways to either, for those patients that don't respond, to actually allow them to respond from the get-go, or for patients that respond first and then progress, we have to find out ways of kind of reinitiating the immune response to those patients. So that's what we call second-line therapy. And unfortunately, at this point, we don't have approved therapy in the second line. If our patients have a BRAF mutation, you've heard from Dr. Davis that you could potentially switch to a BRAF inhibitor. These are drugs that work in a large majority of patients. You know, they do have some durable outcomes as well. And as Dr. Davis mentions, we're actually considering combining those together. If the patient is wild type, you know, a lot of the times you have to think about whether you use IPI alone or in combination, again, potentially like 3, but there's a lot of new things that are coming on. You know, today I'm kind of focusing on the basics. So not going to discuss these specific clinical trials, but there's still therapy. There's Pembro plus lenvatinib. And other cytokines like Nectar-214 in combination with PD-1, there are some really interesting data, and we hope to be able to learn more about these drugs in the next year or so. But we really need to understand resistance, and that's where a lot of research is required. You know, for those patients that resist, how do we reverse that resistance? And so, just again, I kind of have here on the right the fact that with those two drugs, with PD-1 and PD-L1, we've already started a literal revolution in immuno-oncology and in cancer, and it most of the time starts with melanoma. So IPI was first approved in melanoma, Nivo was first approved in melanoma, and now relatlimab is likely to be approved in melanoma. But wanted to share with you that it is actually absolutely remarkable. Every time I update the slide, my number goes up by 1,000. So last time I did it, it was more than 3,000 immuno-oncology agents. Now it's 4,000, and there's 6,000 trials happening globally. And if you look on the right side, you see that a lot of those around combining PD-1 with other agents. Again, a lot of work trying to figure out what should we do to improve the outcomes for patients with metastatic disease. And so just a quick note, I'm not going to repeat some of the things that Dr. Amaria said, but I do want to tell you. So metastatic disease patients, we treat with checkpoint inhibitors. Patients with brain metastases, we treat with checkpoint inhibitors. Also early stage patients, we want to cure patients before they get to metastatic disease. So in the adjuvant setting, as you heard from Dr. Amaria, we use this in the neoadjuvant setting. We're now using it in stage 2 patients. Of course, we have to have a lot of work on trying to understand who to use these drugs in this early stage, because some of our patients may be cured with surgery alone. And then in the neoadjuvant space, again, we're really excited about some of the work that Dr. Amaria has been leading, where we use checkpoint inhibitors, we can cure patients, achieve a pathologic complete response, and even with Nivo or relatlimab, potentially at a lower cost of toxicity, which is our hope. And in that space, again, you know, to conclude, I would say immunotherapy is an actual standard right now in metastatic melanoma. It is the standard for metastatic melanoma in the first-line setting. For metastatic disease, it has a lot of value potentially in the second line, combined with other things, definitely in the adjuvant and the neoadjuvant space. There's a definite role for targeted therapy. Those patients need to be selected in terms of who would benefit most, and there's some kind of triplet therapy approaches that are being used where you combine targeted with immunotherapy. But as clinicians, just so you know, your physician will take into account not just, you know, kind of whether you've been treated before, but I showed you things about how big is the tumor, not in one location, but if there's multiple locations, we call that tumor burden. The LDH levels, which is a serum marker, that we know that if it's higher, it kind of predicts for a potentially worse outcome, brain metastases, And really, how much is, kind of what is our tolerance for toxicity? Do we go for highly toxic agents? Again, technically high dose IL-2 is still available for patients. Do we do something like that? And what is the patient, kind of other comorbidities? A lot of drugs are in development, but I really have to say the drugs that are coming along are exciting and interesting, but also analyzing more deeply the things that we have in hand will really help us understand who are the patients that we should treat with these combinations, and how do we kind of develop newer approaches for those patients. So with that, I will conclude. Again, many thanks to the MRF. I think it's been remarkable how focused the MRF is in advancing melanoma outcomes across the board, from research to patient education. Shout out to our team at MD Anderson, all of our faculty and our staff that make this possible for all of us, and absolutely for our patients. I've had to say, especially with the last phase 3 trial that I just reported with relatlimab, knowing that study happened in the midst of a pandemic and patients were randomized, placebo-controlled, blinded study. They didn't know if they were going to get the relatlimab in combination with nivo or not. But still, patients that are committed to clinical research and to clinical trials are the ones that are allowing us to be able to give more cures to patients. So thank you for that, and I would be happy to take any questions. Thank you.
Thank you so much, Hussein. We'll do one question now and then actually move to brain mets. And then there's been a lot of really great questions in the QA that we're going to come back into our panel session. So Hussein, you used a controversial word. You used the word cure. Can you talk about when is a patient considered cure? What is a complete response? And then a related question from Charles is, what about for patients with late recurrences? What are our options there, and how often does that happen?
Yeah, no, thank you so much, Jen, and thank you for that question. I have to say that, again, as I use these kind of cheeky analogies about, Superman and kind of the T cells recognizing, we try to simplify this on 2 levels. One, because we need to understand it and act on it. But really, when we say cure, it's really driven by the data and the evidence. So interleukin-2, it took us 10 years before we started being comfortable saying, yeah, this looks like a cure. If a patient is walking around not being treated with anything, don't have tumor that we can see, or even the tumors that we see have never changed for the last 5-6 years, then this is what we define as cure. And in fact, with ipilimumab, we actually have that 10-year data from almost 5,000 patients that were treated. And what we learned from that is, if you look at those curves, by the time you get to that, between that year 2 and year 3, by the time you get to year 3, if the tumor has not progressed or recurred, that curve really flattens out. So, what I do tell my patients, I do use the word cure because I believe it, and I think it's happened, and we can see it in those patients. I also tell them that melanoma is so tricky that I never turn my back on it. And I tell them that you will indefinitely be scanned every year if nothing is going on once a year. And you'll talk about the survivorship clinic that you and Michelle are running in the next session. But also I tell them that if at any point they experience an unusual symptom, they feel a new lump, or they have any issues, we will investigate, because I don't trust melanoma either. So it's kind of one of those kind of dilemmas where you don't want somebody to be walking around with melanoma hanging over their head. But the truth is, again, patients that do well with immunotherapy, that have a response, not always complete is good. That means the tumor the T cells eliminated every single last remnant of tumor. But for those patients that are doing well for 2 to 3 years on after response to immunotherapy, it is looking like a cure. So I have been kind of, using that word, as controversial as it could be, out of a deep belief that we are actually doing it.
Great, thank you, Hussein. Okay, we will move on to our last speaker, which is Dr. Isabella Glitza. Again, this one is actually a recorded session. Dr. Glitza is currently in the hospital seeing our inpatient service. She'll be speaking about brain metastases, and Dr. Glitza is an associate professor of melanoma medical oncology. Also sees patients along with Dr. Davis and Dr. Tabi in our brain mets clinic. And she also runs our clinical trials for patients with leptomeningeal disease. Again, our other panelists will also be able to address questions around brain metastases, and we do have a number of great questions that have come in the Q&A that we'll address in our panel at the very end.
Good morning, everybody. First, I would like to thank the organizers of today's meeting for inviting me to give you a quick update on the current therapeutic regimens in the treatment of melanoma brain metastases. I'm Bella Glitza, as some of you might know. I wish I would have been able to join you in real time right now. Unfortunately, I'm currently covering our inpatient service of patients who are in the hospital, so my apologies that I had to pre-record this session. With this, I would like to get started as we have a lot of ground to cover. These are my disclosures. And in short, this is just really the overview of some of the points that I would like to make. I would like to give you a little bit more of background of what is the incidence of melanoma brain metastases, maybe how do they even develop, really again talking about the significance, which means on the overall survival of a patient who's diagnosed with brain metastases from melanoma, but then very excitingly spending the majority of the talk on really the new systemic treatment options for patients with brain metastases. And it's really two big things that we do these days. We use immunotherapy, and again in patients who have a targetable mutation, we use targeted therapy as one of the other treatment options. I would like to maybe familiarize you very briefly with the concept of a multidisciplinary care clinic for patients with brain mets in general. And then finally, I would like to just spend a few minutes on leptomeningeal disease, which is a complication of brain metastases or central nervous system metastases from any tumor. But again, this talk will focus on melanoma only, as this is very close to my heart and we have made some progress in that area as well. So why do we even bother, or why did I even get time to tell you all about brain metastases? Because it's really an important and very concerning side effect or late stage complication potentially from metastatic melanoma. As you know and heard today, melanoma is the most aggressive skin cancer and is leading to the majority of all death, much more than squamous cell and basal cell, which often don't even metastasize. And when we think again about melanoma, one thing that people or physicians or even obviously also patients don't necessarily know that melanoma, of all the solid tumors, which include lung cancer, breast cancer, colon cancer, pancreatic cancer, kidney cancer, has actually the highest likelihood or risk of going to the brain. And when we put this in statistical numbers, we're looking at about 10 to 20% of patients with newly diagnosed stage 4 melanoma will also have concurrent brain mets already at that diagnosis. But then over 50% of patients will develop brain metastases during the course of their disease. And again, the other problem that we have encountered is that sometimes we can control the systemic disease, meaning everything kind of below the neck, but then patients continue to progress within the brain. As you can see, median overall survival, which means from the time of diagnosis of brain mets to the time of death, the median overall survival was only 4 months. And this was thought mainly due to lack of really effective agents for brain metastases, which included really chemotherapy back then only, but also the problem is that not all drugs can penetrate what we call the blood-brain barrier. And again, even the drugs that were able to penetrate the blood-brain barrier had an efficacy of less than 10%. And I'll show you a little bit more data. Again, in our own review from about 10 years ago now, or 11 years ago now, led by Dr. Davies, you could see that the median overall survival was only 4.65 months, and this is at a very highly specialized cancer center. But a lot has changed, and I'm excited to kind of lead you through today's few slides. Now, what are the risk factors? I think patients always ask, and it's a obviously very concerning thought to have. What puts me potentially at the risk for developing brain metastases? And it's not black and white, but what we've seen is an association. If you have cutaneous melanoma as a subtype, if your melanoma started on the scalp, there is a slightly higher likelihood of developing brain metastases. And if you have a BRAF or Nras mutation. Now, that's a little bit hard to quantify, because the problem is that actually the majority of patients will have either a BRAF or an Nras mutation. And just as a reminder, I put here the average numbers, how these are being seen, of 50% roughly in BRAF, and about 28% of Nras patients will have an Nras mutation. Also, another factor that is important is stage, and you might have seen us scanning again in patients with stage 4 melanoma. We're scanning them more regularly in regards to their brains. So brain scans are part of the regular surveillance. However, we might not do it as often in a stage 3A patients because the overall incidence or risk over 5 years is obviously much, much less compared to a patient with 3D melanoma, where the overall incidence is up to nearly 30%. Now, how do those melanoma cells actually get into the brain? And they get to it very similar to how they get to other areas in the body, including the lung and the liver. Again, it typically starts at the melanocyte, if we really think about the original primary tumor. And those melanocytes, once they're able to break through the dermis or into the dermis, they can get access to these capillaries, which are just tiny little blood vessels, and they can shed right into the blood vessel. And then it's kind of like dirt in a water hose. It just kind of goes everywhere, right? And so they can travel around through the body, and they can arrest in capillary beds or areas where they kind of branch off. And again, the brain has a lot of blood vessels, so they can end up in the brain, and then through a different factors, they actually can kind of squeeze themselves to the blood-brain barrier and then actually get into the meat of the brain, so to speak, and then just start to grow and get worse and form new colonies. And again, this process can also happen potentially if you had, for example, a lung metastases or liver metastases. As soon as these melanoma cells have access to vasculature or blood vessel, they can pretty much just go wherever they want to. So thinking though about the past, so we're still kind of thinking about why was it so bad? Why was the overall survival only 4 months? Part of it was probably because patients used to be excluded from clinical trials for a variety of reasons. And this is really more for brainstorming and maybe food for thought, because again, we've changing this now. The new treatment paradigm is that patients with brain mets absolutely should be included in clinical trials or should have their dedicated clinical trials. But it used to be really that the poor prognosis really was obviously not very encouraging. Some patients experience a rapid neurological decline, performance status. If you're wheelchair bound or bed bound, it's impossible to come to get treatments, and the use of steroids, which we know can counteract at least some efficacy with immunotherapy. The other question was, can the drug actually get into the brain or the CSF? And that is a legitimate concern. If you give it by mouth and IV and it gets into the blood and you can see it in the plasma, but it doesn't cross over, then how is this even going to work in the brain? And we've learned that, for example, with immunotherapy, it might not only be the level, it might just be the fact that immune cells can actually also crawl into the brain or in the brain metastases, similar to how the tumors kind of crawled out into the brain. And finally, really the summary is the brain is different than the rest of the body. I mean, we always talk about how precious our brain is, and then this is, you know, the central control station, but we do know, and I'll share a little bit information later on, the whole immune environment in the brain is definitely different than, for example, in a lung metastases and in liver metastases. So this slide is really, again, kind of still lingering in the past because I'm trying to really excite all of you for the newer data to come. It really shows you that really between 1988 and 2012, these were the only few trials that really were run worldwide for patients with melanoma brain metastases. And when you look at the overall number, overall really, really very few. And I should actually correct myself. Not all of these trials were actually specifically for brain metastases patients. Some of these just allowed patients with brain metastases on it, which actually was a big deal even then. And however, though, you can see that the overall intracranial response rate, which is this ICR, is low. It's not satisfactory. It's 2.2093. It's not where we need to be. And I'll be honest with you, I'm not sure I believe the 28% or the 25%, as again, chemotherapy historically has just not really improved survival. And here, a little bit over, you can see the median overall survival, again, very just grim prognosis. And again, luckily we have made some headwind. And again, I'm happy that physicians before me and the community and patients rallied to just enroll patients on trial, even with brain metastases. So what do we have to think about? So when a patient now these days walks into our clinic with melanoma, either newly diagnosed brain metastases or while the patient has been on other therapies, and this is now a new development, We again need to think about immunotherapy as one of the considerations. Obviously, we also need to know, was the patient on prior immunotherapy or not? We also really would like to know, does the patient need steroids or is the patient on steroids? Because as I just mentioned, it can really decrease the efficacy of the immunotherapy. And how about combining it with radiation? Is it safe? The answer is yes. But targeted therapy for patients with, for example, a BRAF mutation, we have to consider the expected duration of response, meaning how long will the therapy, the targeted therapy, keep those brain mets at bay? And what's maybe the mechanism of resistance? Because even though we have to acknowledge that the resistance happens, what are future trials and future approaches that we can take to prevent the resistance to either happen, or we use new drugs to actually treat the patient once they progress? And then again, integrating other treatments, again, as I mentioned, for example, radiation, but again, the role of a multidisciplinary care model, which is just really, really important. So let's start first with now the last 10 years. So initial immunotherapy trials were done as single agent. And single agent means just one immunotherapy, not the combination. And naturally, because ipilimumab was the first drug that was approved for the treatment of metastatic melanoma out of the new immunotherapy drugs, was tested, and excitingly, in asymptomatic patients showed a response rate in the brain of 18%, which is very similar to what we observe in the body if we would treat a patient with ipilimumab without brain metastases. So we expect a response rate of maybe somewhere 12 to 16, 18%. However, as you can see, in patients who were symptomatic and might have even required steroids, the response rate definitely drops down to just 5%. So again, definitely not a great option for symptomatic patients. And then along came the anti-PD-1 agents, which is pembrolizumab and nivolumab, which again, I assume most of you have heard about. And again, definitely slightly higher response rate than maybe with the ipilimumab. However, again, still not really where we would like to be, not the blockbuster. However, I think there were a couple of things that we learned from these early trials, not only that trials for melanoma patients with brain mets are feasible, but also that these agents were actually safe in the brain. They didn't cause typically uncontrolled swelling. We could also see that if a patient was responding, they actually typically respond for a very long time, which is a proof of principle. We also learned, as I just pointed out, that if patients were on steroids, it just didn't seem to work, and therefore they were excluded from many subsequent studies. And we still really didn't have the lottery ticket or the win, because we really still need higher response rates in melanoma brain metastases. And voila, sure enough, Dr. Taube, one of my dear colleagues here at MD Anderson, led a national study called Checkmate 204, which now included the combination of double immunotherapy using both ipilimumab and nivolumab in combination. And really, not surprising, but excitingly, I should say, we did see in those 94 patients treated, again, no steroid use whatsoever, that the intracranial overall response rate was 55%. So more than half of the patients actually responded. And what that means, it's a meaningful response. And my cat just joined me, I apologize. And so you saw that 26 patients actually had a complete response. And the majority of the responses were still ongoing, which is just absolutely delightful to see. Overall survival at 1 year was 82%. And to maybe just kind of quickly explain again what that means. So as you can see down here in the lower right corner, talking about overall survival, you see that at the 12-month mark, the 1 year, about 18% of patients unfortunately had died. But when you kind of look out is what we call the tail of the curve, it's kind of pretty plateauing. And whenever we see a plateau in oncology, when we look at overall survival curves, that means that the patients are kind of just doing well. They're just surviving, which is wonderful. So we get very excited, not only about this tail, this plateau, but how high this is, that this is really at 1 year at 82%. And so what did we learn from this trial? It was definitely a new standard approach for melanoma brain metastases, breakthrough really data, and many patients again alive and well, even long after treatment. Now, totally switching the agents or the drugs. Now let's talk about targeted therapy. So this is typically BRAF MEK. And again, as a reminder, about 50% of patients with cutaneous or skin melanoma will have a BRAF mutation within their tumor. We have 3 approved combinations. And the exciting thing is, again, that if we look at the data of patients that take these drugs without brain metastases, the responses in the body, in the lung, liver, again, bones, lymph nodes, the risk or the chance of responding, I apologize, is about 70%. And the duration of how long these drugs work in average, again, everybody's different, is about 11 to 15 months. And this is in patients without brain mets. So there was a study led by my dear colleague, Dr. Davies, who's also happened to be my boss, using the combination of dabrafenib and trametinib in BRAF mutant melanoma brain metastases patient. And you can see that this was actually exciting results as well. We had 60% response rate, which is kind of similar to the responses seen outside the brain, 80% control rate if we also counted stable disease. And this was exciting because it was even seen in patients with steroid use, and the onset was very, very rapid. So we could see those lesions shrink within even days in some cases. However, and this is the unfortunate part, the median duration of the response was only 6 months, so about half of what we would expect for the body, and or 50%. And this was just really kind of, I don't want to say discouraging, but we knew that we need, again, to do better. So we knew safe and very high initial response rate, even in patients on steroids. But again, one of the caveats of this therapy approach is the shorter duration of response in melanoma brain metastases. And why is this? We don't really know all the answers to this, but again, a team around Dr. Davis's lab, led by Grant Fisher, really kind of identified some of the features. And this is really more now pathology and data in the laboratory, but it's exciting because one of the things we learned that if we look at brain metastases and compare them, for example, to their lung metastases or liver metastases, they're just less immune cells within the brain metastases. They're just in general or less immune cells. There's an activation of something called the PI3 kinase pathway, which is some of the pathways that keeps your cell kind of going. They also use a different type of metabolism or upregulate this compared again to melanoma metastases that are not in the brain. And it was interesting because all these kind of weird findings with less immune cells, activation of different pathways and a different metabolism were also found in brain metastases from other cancers. So there is something specific really about the brain environment that is upregulating or changing some of the key features that we observed in melanoma. Now, why is this important? Because I just told you that unfortunately a good number of patients will progress on targeted therapy. And again, finding information like this might really inform us for the development of future clinical trials. Can we potentially interrupt the OCFOS metabolism? What are potential things, how we can interrupt the PI3 kinase pathway? Again, some of these investigations are still in the very early stages. However, again, it is very important that we include as many patients with brain mets in trials, and that we also smartly develop brain metastases trials for our patients. Now, patients always ask, how about radiation and immunotherapy? And I just wanted to put the slide up, not again to go through super granular details, but I wanted to tell you that we do have some data now that shows, and this was a meta-analysis of all these papers pulled together, that number one, when you give immunotherapy together with radiation, for example, gamma knife or gamma ray, that the outcomes or the overall survival seems to be better. And this is not only numerically seen, and as you can see, nearly 65% versus about 52% at 1 year, but also shown in this curve here where this red line shows that patients were treated with immunotherapy and radiation therapy close together. And so we can not only do it, we've seen that it is a fairly safe approach, but there might actually be some synergy and some benefit for our patients when we do that. Now, really, and I don't have to tell you this, but every patient is unique, and we have to look at every patient at all their uniqueness. And you can just see here an example of 4 different brains, all of them with brain metastases, one with the cystics, one kind of the smaller peppery nodules. This is just a single tiny one. This is a huge single one. And again, it all, the uniqueness is not only the patient, the carrier of this brain metastases, but the presentation, the symptoms, the location, size, number of lesions. And again, all this, including again, the patient, him or herself, will really guide us in regards to what treatment is needed. And typically there are multiple specialties involved. And why I'm saying this is again, because it's so exciting that we were able to develop this melanoma, or actually not melanoma, but MD Anderson Brain Metastases Clinic. And the goal, as written here, was really to establish a world-class interdisciplinary brain metastases clinic, not only to do novel clinical research that supports establishment of new standard of cares for patients with brain mets, but really to also make it more streamlined for our patients. We opened in 2019, started initially with melanoma, breast and lung, and then now open to all cancer types. And the way that we're thinking about the melanoma brain metastases, I keep on saying melanoma, it's not just for melanoma, but the brain metastases clinic is, if you think about it, if you typically see your doctor, you have to go through all those different specialties, the radiation doctor, the neurosurgeon, the medical oncologist, and you also have to hope that all of these really continue to talk to each other about the plan moving forward for you. And this can sometimes span over not only a week, but 2 or 3 weeks. And we kind of flipped it around. We make the patient come to our brain metastases clinic, and all the specialties come to the patient the same day, the same afternoon, after we have reviewed the case together, discussed the next step. And so this is really just an incredible, I think, new clinic for our patients, now 3 years old, that really, I think, has been very successful. And again, from the melanoma group, Dr. Taube, Dr. Davis, and myself staff it. And then again, we have colleagues from all the other departments who really dedicate their time to help our patients. Now, the final last few slides, I would like to talk briefly about leptomeningeal disease. And again, I tried to throw in some pictures to maybe tell you how difficult it might be, or how different leptomeningeal disease might look like. So for example, if you're looking at this brain here, the second from the left, you see this white little coating inside of this like fluid-filled sacs, this black holes. You see little nodules in this patient here, and really here you just see like diffuse little white jigsaw lines. And what it is, leptomeningeal disease means that the cancer cells have made it into the cerebrospinal fluid, or CSF, the fluid that really floats from the top of your head all the way down to your sacral area and back up. And the cancer cells therefore can kind of freely float around, which means you really very rarely can treat it with just focal radiation, because again, you might radiate one area, but then they kind of just float to the next area, or might be floating around and building new colonies, kind of like little glitter in a snow globe cone that you just shake. And what is maybe to know about leptomeningeal disease? It's often later in the disease course. Most of the time, patients have also brain metastases at the same time. Unfortunately, the incidence is rising, maybe because we're doing a better job detecting it or diagnosing it earlier, but also because we probably control the systemic disease, meaning everything below the neck in the body better. And unfortunately, though, the reason why I say unfortunately, it is rising, the incidence, because again, it is associated with very poor prognosis. And to put it in numbers again, you remember the brain metastases were somewhere between 4.6 to maybe 4 months, maybe even a little bit higher in some other data. But when we looked at our own data internally and had actually 178 of melanoma LMD patients that were diagnosed between 2009 and 2015, the median overall survival was only 3.5 months. Actually, a more contemporary cohort by another institution had a significantly smaller number, but they maybe were a little bit more contemporary, because this was really a time 2011 to 2019 where we already had access to the new immunotherapies and the targeted therapies. But you can see again, median overall survival of only 2.9 months. And so what do we do here at MD Anderson? This is really not as advertisement, but I think, again, I'm excited that things are happening and that things are changing. We, for example, use immunotherapy and put it straight down your spinal fluid, right? So we put it straight into the snow globe so it can kind of mingle around the cancer cells and kind of bathe to a degree your brain and the outside of your brain, the lining of your brain, in whatever drug we're doing. And we do this through a little catheter called a Maya. It's like a little port that's right under your scalp. And then we can instill various immunotherapies right in it. And one of the old ones that we've used is interleukin-2. Some of you might have heard it. And the overall survival of a cohort of 43 patients that we recently published went up to nearly 8 months. And again, it's still not where we want to be, but it provides, again, a bit of a proof of principle that this can work. And again, that a subset of patients might do well. We also have done things like giving patients their own immune cells back into the spinal fluid. We've done this in 2 patients. And the current clinical trial that is ongoing using novel immunotherapies with nivolumab, again, right into the spinal fluid. And the overall survival is 4.9 months, which again, in average doesn't sound great, but we have some patients that really had an outstanding survival so far. And with this, I would like to thank you very much for your attention. I hope this was useful. I hope you learned something. And again, it was my honor and privilege to spend Saturday with you. Thank you so much.
Great. Okay, thank you so much. So we are actually now running a little bit behind, and I think our panelists have actually done a fantastic job of addressing many of the questions that have come through around on the QA. And I would actually encourage everybody to make sure to go back and actually read those responses. We've had some very interesting questions around monitoring circulating DNA, around toxicity management, and around what do we do with resistance. I would like to just ask just 1 or 2 questions of our panel before we move on to a 5-minute break and then our next session, which is, I think a lot of the questions have been focused on this idea of, we have a subset of patients that have achieved tremendous benefit, but we have other patients that have significant toxicity from our therapies. And then we also have other patients that are either do not respond or later have recurrence of their disease. What I would like to ask of the panel is actually, where do you see us going 5, 10 years from now, as far as actually being able to address these 2 specific issues of how are we going to overcome resistance, improve our overall response rates, and better manage and thwart toxicity?
I'll take the first stab. It's clearly a wide-ranging question, but obviously that's what we're striving to do. I mean, one of the things I did not include is how many clinical trials we have at MD Anderson. We have actually close to 25 that are up and running right now, where actually almost each of those questions are being answered in a different setting. We have for instance, a clinical trial that is upfront of ipilimumab and nivolumab combined with a drug called tocilizumab that may actually exactly do decreasing the toxicity and improve the efficacy. So that's one thing we're trying to do with biologics. We also have a number of trials for patients that have already received immunotherapy, progressed, and we're trying to reverse that. So I kind of mentioned in my talk briefly how there may be different types of resistance clinically. Like if you've never responded to immunotherapy up front, your tumor may be doing something different than if your immune system saw the tumor, attacked it, killed it, got a period of a partial response, and then the tumor learned how to resist. It could be a different mechanism at play. So I think our work and a lot of, kind of investigators, that's not referring just to MD Anderson, are trying to understand what is the mechanism that is leading to resistance and trying to reverse that specific mechanism. Again, out of the 6,000 trials and the 4,000 agents, hopefully we would be able to be very specific in how we do this. But we are kind of some years behind on that, but ongoing work. Go ahead, Dr. Davis. I see your raised hand.
Yeah, well, and this is one of the times when actually I'd like to highlight a little bit Dr. McQuaid. So Dr. McQuaid's done a great job of talking about the work that all the speakers have done. But, as much as we traditionally have focused on combining new medicines together, trying new medicines, we're also getting a much better understanding about other factors that may impact the risk of developing toxicities, or again, ways to make immunotherapy work better. And so Dr. McQuaid has been working recently with Dr. Jennifer Wergo and just recently had a paper published in a really good journal called Science, looking at the impact of people's diet. And I don't know, Jennifer, if you want to talk a little bit about the possibilities for actually lifestyle modifications as maybe a new area that may help us to both make immunotherapy and targeted therapies work better and potentially even reduce side effects.
Thanks, Mike. Yeah, and actually, Lorenzo Cohen, who is also part of this work, will be part of session 2, and we'll speak about some of that. But we're really trying to address one of the key questions that our patients ask when we talk about, 50% of our patients will have response to these therapies and 50% won't necessarily. And so a question that we're often asked is there anything else that I could be doing? And so that's really what this research is focused on is, how do we actually give patients guidance on are there things that you can actually also be doing to improve response or overcome resistance? And Dr. Cohen, as I said, will address this in further detail in session 2. We'll take one last comment from Dr. Gershenwald and then give everybody a 5-minute break.
So one of the key pillars of being able to achieve some of the milestones that have been highlighted over the last couple of hours are the partnership that you as patients and caregivers have provided to us in your willingness to invest in this journey, not only for your own personal treatment, but to collaborate and perhaps collaborate with allowing your tissue or blood to be used for future use with no necessary gain that you will definitely get out of that contribution other than knowing that it's going for hopefully initiatives that we can continue to raise the bar. And so I think over the next 5 or 10 years, as we learn more and more about the biology of the disease and what triggers resistance and toxicity and response, we can go back to tissue that's already been collected in at other times and test some of these hypotheses that then build on future trial design and future investigative study in the lab in collaboration with the clinic. And so for any of you who have participated in any of these trials or in our biobanking effort, sincere thanks. We know that it's an investment and we hope that it will continue to pay off for all of us going forward.
Thank you, Jeff. I think that's such a beautiful way to end this session. Not only do we really want to improve outcomes for all of our patients, but we want to learn from every single patient.